Okay, can y'all hear me okay? Sort of a small, hello, can you hear me? Okay. I'll go ahead and call the meeting to order. Appreciate everyone being here. And I just have a few comments for the chairman's report. We got through last year's budget and everything's been completed and turned in. I'd like to recognize Dr. Medeiros for all the hard work leading the budget committee. We're getting better each year and getting things in on time and keeping up with things. And thank Katie for all her hard work. She knows the budget really pretty much off the top of her head driving down the road, but so we appreciate that. It's hard to believe the 2025 legislative session is it's not that far away, and new budget things are coming our way. So the committee's already started. A couple of sort of big points. The American Association for the Surgery of Trauma will be meeting next month, I think September 11th through the 15th or 14th, something like that. And we actually had, that's hard to get a single manuscript on or presentation, become now an international meeting, but we actually got two papers approved to be on the main podium presentation. So they are the economic impact of decreasing state trauma mortality on lifetime personal income and state tax revenue. And that, you've heard that talk. Dr. Robinson was sort of the brain thrust behind that, our chief of neurosurgery, former commission member. I think I presented that and that's 1,800 lives a year that were saved in 2020. And then what he drilled down and looked at the tax implications of that back to the state coffers, and it's a very positive return on investment. So that's been presented, just the data, not the paper, just the data. We use that to get an extra $4 million last year from our legislators. As we showed, we've done a good job in decreasing mortality. So anyway, that's been formalized now into a formal presentation and paper, and will be presented. We're also presenting the impact of the American College of Surgeons trauma verification on a statewide quality collaborative. As we went with ACS consultation and the nation for the level 1 and level 2 centers, that was about a 5 to 7 year really project, just a slow, methodical project. We gave everybody time to be successful, and most people were able to make it across the finish line. And so that was a great success story. All our complication rates came down with our TQIP data. So this was a huge success, and that was accepted for presentation as well. And so we're very excited about that. This year's AAST meeting is also being held in conjunction with the World Trauma Congress. And our very own executive director here, Liz, has been asked to give 2 talks to that. So the state of Georgia is really well recognized at the national level, and we're thankful for that. As Liz and I were sort of putting together the manuscripts and getting ready for the AAST meeting, she looked back at the publications from the commission and from all the stakeholders' hard work. When we publish under the aegis, if you will, of GRIT, which is Georgia Research Institute for Trauma, which is made up of every trauma medical director and every trauma program manager of the state for level 1 through level 4. So everybody gets credit. If you go back and look at our papers, it has the authors that actually just wrote the papers, and then it has, and on behalf of GRIT, or the Georgia Research Institute for Trauma. Monitor those. Liz has that list. If any of you all need that, the TMDs for their CV, you're welcome to that. Please list that, because you all get credit for that. But anyway, it turned out to be 10 papers. That was more than I'd realized. And with these next 2 that are being presented, there'll be 12. So that's 4 papers in the Journal of Trauma and Acute Care Surgery, 4 papers in the American Surgeon, 1 paper in the Journal of the American College of Surgeons, and 1 paper in the Trauma Surgery Acute Care Open. So kudos to everybody. When we work together as a state, it's really amazing what we can accomplish. And then lastly, I always try to thank all the volunteers, you know, that's all these accomplishments. There's only a 9-member commission. You know, the huge work group, I think we're up to what, 13 committees now? 13 committees with how many people are on there? 100 and something? Over 200 stakeholders. So that's where all the work is done. And we're just sort of the conduit to report out. So we are extremely happy and thankful for all those volunteers that don't get paid anything that make trauma care better in Georgia. And finally, Liz and I were, you know, it's about the time of year every so often we go back and look at the committees for the commission and just look at assignments. There may be some new assignments coming, and if there's something that if you're stuck on a committee, commission members, and you just hate it, and you want to move to another one, now's the time to let me know as I look at it. If there's something you really have a passion for and you want to know, now's the time to let me know. And then if there's some committee that's hurting that nobody signed up for, you may here for that committee. So just please be happy and patient to my face and just say you love it before you do or not. So, all right. With that being said, that completes my chairman's report. We'll move on into it looks like we have quorum established. I've got one, JJ, 1, 2, 3, 4, 5, 6 here and 7. There's John. So, and so who's online? Pete's online. So 8. Okay. And then Courtney, I think, had a meeting he had to go to. He couldn't make it. So we're in good shape. So Liz, I'll turn it over to you for the executive director report. Okay. Can I get a motion to approve the minutes, please? And a second. You have a second. Okay. And open for discussion. Any corrections or concerns with the minutes? All right. Hearing no corrections. All those in favor, aye. Aye. Any opposed? Okay, the minutes are approved.
For reminding me. Okay, sorry about that. Good morning again, if you didn't hear me. And welcome. Just a few updates. I'm going to actually turn it over to Gabby because I've been wanting the commission members as well as all the stakeholders to see with our sort of operations tracking. Gabby has worked really hard over the last year or so to create a tracking board to show you. Actually, she's popped it up there. And for those of you, the commission members, you actually have it in your packets on page 19. This is our comprehensive repository and performance monitoring. How are we doing getting your contracts out to you and getting executed? When we get invoices in, you know, back about 5 years ago when I first came, we had a backlog of invoices, purchase orders, all that kind of stuff. So we had to come up with some way to track and make sure that we were being efficient with how we process. We don't want people waiting around for payments and things like that. So, so Gabby has it sorted. She looks at this monthly. She looks at if there is an invoice delay, what is the source of the delay? Is it on the procurement processing end, on the DPH side? Is it maybe I didn't get the email to sign it? Is there some delay on that? And we just want to make sure that operationally we're being as efficient as we possibly can. And we look at that. So hopefully that is resulting in timely payments. I know for a long time, our tech coordinators, we really struggled with that. Those seem to be issues of the past, and this really helps us stay on top of it. In addition, it helps us look at when the contractors aren't turning in deliverables timely. And so we can follow up with them and make sure. And again, this all helps us keep ahead of that purchase order thing so we don't have funds sitting around on a purchase order that are at risk potentially for OPB coming in and closing. Right. So, yes, sir.
Just a quick question. So is Gabby the only one that cuts the checks for the contracts, or is that Katie, or who else does that?
It's actually, yeah. Gabby reaches into her personal checkbook. It's actually like a 3-part process. Like Gabby processes, Katie checks budget, I approve, and then it goes to DPH. So it's really a 4-part process.
So who actually cuts the check?
DPH. Yeah.
So
great question though.
Yeah,
Thanks.
didn't know.
Yeah. Yes, and that is part of our administrative attachment is because we're so small, we don't have that procurement HR infrastructure. And that is what we leverage off of DPH, is that we, and I see Natalie shaking her head because she's at a small agency too that's attached, and you know how this works. So that we don't have to invest in that infrastructure. We use that, but I have to say that that's why we developed this robust tracking, because it was really hard for us to see where some of the barriers were using the DPH system, because we don't have 100% sight line into what their processes are. Hopefully they're moving to a new system and that will be a little bit better. But for now, this has really helped us stay on top of things. And really, you know, historically too, we had trauma centers who weren't getting current FY payments because they had previous deliverables that were never adjudicated. And so now, you know, if you all know, if you're contracted with us, you're gonna get an email, and Gabby has automation set up through this, almost too much. Some people are like, okay, turn the sensitivity volume down a little bit, so that you know, things aren't falling behind. I mean, if we contracted with you, it's because we have important business to do with you and you're helping us meet our mission, so.
We're having some technical difficulties with online, with the City of Madison AB, so I'm gonna try to figure that out.
Is there any way we can turn her off? Maybe we can turn her volume down. She just talks inside.
No, it's the Zoom.
It's the
that's
Zoom
connected to
recording.
The whole meeting that's going on and off. So.
Keep showing.
Yeah, thanks Gabby for the hard work getting that together. Because again, from a business intelligence sort of standpoint, it's been kind of how we make sure we're staying on target. In terms of the 61 million stabilization proposal, as Dr. Ashley said, the preparation for the upcoming 2025 legislative session is already well underway, and the Senate budget analyst, Caitlin Little, who works with Senator Watson, I've already had 2 meetings with her about what next session might look like. I was just informed yesterday that OPB will start having meetings with state agency heads at the end of September. The OPB budget instructions for this year are included in your packet just for your situational awareness, but this year they're using a zero-based approach, which I think most of you in the hospital setting are used to. You know, you start with nothing and you have to build your case for why every dollar is necessary. And I know, you know, we have our dedicated funding, but you know, I think we have tight stories, as we know, about what every dollar that we spend. I think we're up to 9 cents on the dollar with that additional 4 million for levels 1, 2, and 3. So, and all inclusive, everybody's funded this year. So it's a great success story for us. So we look forward to what's coming up next. I put this note on here about, you know, our ACS system consult, which you remember happened in January 2023. The biggest, I mean, there's a lot of little spawn-offs from that, obviously, but at last meeting, Dr. Scoggins from Mercer, who helped us put together that comprehensive rural needs assessment, went over that. There was so much meat in that report, and we're going to get back together again with Nita Ham, who was instrumental in that as well. State Office of Rural Health has been an amazing partner for us, and where we'll have our meeting in November and get all the stakeholders who responded to the survey put together kind of a Mentimeter in Dr. Todd's style, because that's such a great mechanism to use, because we want to come up with some interventions that will be palatable to the folks who are actually going to participate in some of these things. Most of the needs were around education. Surprisingly, it looks like they can access trauma care and get patients accepted. They just can't get patients moved. That's a known issue. And hopefully next year through the legislative session, we can get that EMS pilot up and going. Dr. Ashley already mentioned our 2 abstracts and the 2 papers. Coming up on Monday, really exciting. If you recall, back in May at Chateau, we had the administrators met, and Val Wrinkle from TCAA did a finance workshop that was a lot of information packed, jam-packed into about an hour and a half. This time, what we decided to do was, Dr. Medeiros, please comment on this if you have anything to add, but I know you've been trying to build a hospital finance dashboard. And in that vein, and in the vein of the commission funding is supposed to be the payer of last resort, we're embarking on a pretty robust educational effort with the hospitals to optimize their revenue charge capture for activation. So we've asked them to get their revenue cycle decision support, all the people that have anything to do with either putting together charges, clinical charge documentation overview, all aspects of revenue cycle, as well as claims, to get together on a call. We have almost 170 people registered now. So people are coming out in droves for this. So this will be great. And Val's going to do something that I have to say, I looked at her PowerPoint and some of it's a little bit over. It's so revenue cycle intense. I don't understand a lot of it, but it'll be great for them. From that, we want to come up with 2 metrics that we add to the PVP that you'll have to track, like your number of highest level activations. Was it coded correctly, et cetera? And then go back and looking on the claims side to see yes or no, did you get a payment for that? So Dr. Ashley and I were asked on a couple of occasions last session, some of the physician legislators were knowledgeable about activation fees, and they said, well, you guys need all this money. Are you not getting revenue from trauma activation fees? And honestly, we couldn't answer that question. We know that some folks are charging, but we don't know, we don't want to know, how much money everybody's bringing in. That's probably not discernible for the patients who are admitted, but we want to glean some sight line into what level of success you're having with both the charges and actually getting the claim paid on it. The registry startup grants that were approved as part of last year's budget are posted. And we have a couple applicants for those already? Yeah, two startup grants for level 4s. Excited about that. That'll help take the burden off of them so they can at least get the registry going and then work on what they need to do to become compliant with our DPH, OEM, S&T partners to get state designated. So hopefully that will help us expand a little bit further into the southern areas of Georgia. PVP criteria is coming up. We've heard everyone loud and clear that some of the things around meeting attendance for trauma centers is a little problematic. We're going to use sort of the Michigan model and do like a tiered, if you've attended 4 out of 4 full, 3 out of 4, 2, that kind of thing, to make it a little bit easier so that it's not all or none on the attendance. So we'll put that out for feedback once we have that finalized. We ran into a couple issues with that because we're moving the timeline again. We're never satisfied with the status quo. So that will be posted, more communications coming forth about that. I think I covered everything. I've also included a copy of the strategic plan in your packet. That is primarily a very agency specific plan. And again, more in line with how we track business. It's not really meant to be like an overall trauma system strategic plan, which we probably do need to get back to and do. We haven't done really since our initial ACS consultative visit. And then again, our November meeting will be in Cordele. Will take place on National Rural Health Day. We have some exciting things in the works planned for that to help celebrate all the progress that's been made in rural Georgia. And lastly, the bylaws work group is going to meet immediately following this. We'll just meet right in here. We can probably pull a few chairs around here if that works for you, Dr. Medjugorje.
Liz, one quick question.
Yes, sir.
You mentioned pay for performance metrics for activation charges. Can you just, no, it's not going to go into 26, but what were the 2 items that you're thinking about or we're thinking about including, just so I can educate the finance people?
Yeah, great question. And hopefully they'll get, besides this webinar coming up Monday, we're going to do another follow-up webinar. And we're asking TCAA to kind of help us on what are 2 good, they kind of using us as a guinea pig a little bit, like what are good things to track.
Okay.
We think one thing will be and this is going to sound very like a foreign language if you're not in the trauma billing world, but the FL14 type 5, the patient type that you have to, check in order to be successful with the claim, although now I'm hearing you don't necessarily have to have type 5, right? The type 5, yes. The type 5.
I actually know what that.
Know your type. To count the total, so total number of top tier activations
Right.
should at least equal FL14 type 5 or more, or you should have more. If you have more activation levels, you should have more. Then the other thing we proposed, not totally fully baked on yet, and I think more dialogue will come out, is on the claim side. Regina and I have talked about this for years, but it used to be that only outpatients were, you could actually see, you could drop the charge for the activation and see what you got paid. Now, when the patient gets admitted, it's rolled into the DRG, but apparently on the claim, it will say yes or no if that was paid. So we want to know, of the times you dropped the charge, how many yeses did you get? So then we can answer that question. Well, activation fees are only allegedly paid for on 50% of the cases, 60% of the cases, 75% of the cases. Any comments, or the OIG audit piece you might want to add? Oh, your mic, sorry, you're sharing.
Oh, she doesn't have a mic, yes.
We silenced her, Dr. Dunn. Was that on purpose for some particular reason?
No, I lost my train of thought. I think it'd be really interesting too, Liz, if we can add, if it's not too cumbersome, we can talk with the finance people that are on the call on the 19th of which payers are denying versus which payers are paying the fees. And another thing that we're discovering is doesn't appear to be a standardized process of who the ownership of making sure that type 5 is put on the claim for trauma patients. How do you define a trauma patient? As I spend more and more time with Valerie, I'm realizing it's really more any patient who's an activation as opposed to any patient that meets registry criteria, because you may have a non-activation and the type 5 may skew your number. So your type 5 is specifically for that readiness cost as an offset. So I think that's something else we need to tease out, is how do we define the patients that require the type 5? And then within your institution, who owns that? Because there seems to be some conflicting information. If you don't know who the owner is, then you can't educate them as to which patients it's most appropriately to put it on. So I think we're finally getting to a process where we got the right people to fix some of these things, to maximize our reimbursements and help people understand. I'm excited that there's so many folks on this call. It is very, the first half of it is more historical. It's more like your care coordinators that assign your DRGs and go around and tell you need to add stuff to your notes. That's sort of the first part of it. And then the whole remaining 75% is rev cycle. So since we have a lot of rev cycle people, I think it will help them and understanding what's in the rules, what they can and can't do, because there's language barriers. You can't build critical care, yet you can. So we're going to try to answer a lot of those questions and get a group together to be on the same page with it. But if we can just fix the type 5s and then track, because it is line item, which I didn't realize, paid yes, paid no, or what they pay on a claim, so we can look at either percent denials or percent payments, whatever, however we want to slice it.
This will be really important. That's why I wanted to know what the two metrics were, so I can, hold somebody in my institution accountable to make sure that you're in charge of the X. But in addition, Medicare and Medicaid are now increasing their number of hospital audits, and the number one thing they're looking at is activation charges. So this will help trauma centers make sure that they're charging activation fees appropriately, because if not, Medicare is going to be recouping millions of dollars from your institution.
Yes, and they want to see your finance policies, how you define your top tiers, how do you make sure that that's what you're charging? Is it where it's the medical necessity that defines that? That's what the OIG audit, I understand, was primarily driven from non-verified and non-designated centers who were charging activation fees. But the other piece is medical necessity for the charge level. And we can really help by coming up with sort of a template of a base finance guideline for folks to use, and then they can adapt it to their institutions as appropriate. And how you measure that and how you put your finance PI teams together. And I think that that would position us very well if we ever did end up having an audit, because there would be continuity in how we handle it. And there'll be finance teams with the trauma teams that look at these charges. So they know that they're just not going out the door. Somebody's reviewing them, and, you know, mistakes happen, obviously, but a little tighter process.
Awesome. All right, and I will just wrap up by turning it over to Crystal Shellnut, because you'll notice in your packet, all of your RTAC reports have been moved up to the front. We'd like to put a little bit more focus on this. Crystal's doing a lot of hard work trying to get everybody together. So if you'd just like to hit the high notes for everyone, Crystal?
Yeah, absolutely. Thank you. So if everyone would take a minute to look through the RTAC quarterly reports, that's something they've been submitting for a while now, and there's a lot of really great information in there. A couple of notable changes with the RTAC. We are in the process of rebuilding the Region 9 RTAC. For now, I'll be serving as the interim coordinator, and it's really convenient from Athens to Region 9. But I've met a lot of really great people in that process, and we're really looking to kind of pour into that region and hope for a lot of really good redevelopment there. I had the opportunity to attend the region council meeting last month, and we had several people who expressed interest in serving on the committee. So I really think we're going to have a lot of traction. We expect to start some virtual meetings next month. As we kind of work to redevelop that, we'll be needing to identify a chair, a vice chair, and of course a coordinator at some point, but good motion already and a lot of excitement. So the other RTACs, we've got some really great work going on with the RTAC coordinators right now. I have just a couple of notable things pulled out of their quarterly reports. So we have 5 RTACs that are currently working on pre-hospital blood initiatives. We have 2 regions that already have product deployed. So Region 2 and Region 10 have plasma and or whole blood deployed in the field right now. The other 3 are in the process of working out supply chain and logistics, and of course the financing of that. But we're seeing a lot of great success coming out of those pilot projects. So we're happy to continue to support them moving forward. We've got, let's see, almost all of the RTAC coordinators now have either robust trauma conferences that are already occurring, or they're developing them. I know the Region 1 conference is coming up soon. I attended a meeting yesterday for Region 4's conference. That's going to be in October. And they're using a lot of the feedback that they got from the educational needs assessment. Last year, we conducted that for the first time. The feedback that they got from those reports, they're pushing into educational offerings for pre-hospital and in-hospital providers. A lot of pediatric trauma came out of that. So we're seeing a lot of classes being developed around that. Of course, blood product, difficult and advanced airways, things like that are what came up in those surveys. So if you don't know your coordinator, we'd appreciate you reaching out to them and making sure that you have those relationships. They really are working hard, and we appreciate all their efforts. So July was the most recent open application period for the Stop the Bleed kits. We received 2,109 kit requests from across the state, which is really great. The breakdown of that, about 1,100 were for schools and buses, 162 for colleges and universities, just under 500 for law enforcement, and another 300 for our government other. That's our fire departments, EMAs, other organizations like that. To update the numbers for those organizations, we've got our schools are 99% complete. We've kind of held at that number. We've got 2 counties that we're working through. Our school bus completion is up to 92.5%, which is a huge accomplishment. We've especially seen a lot of progress in the Region 8. Anita has been working diligently to kind of check those additional counties off the list. And then the last map that I have updated for you, this is our expanded project. This group voted 2 years ago, I believe, to expand this to law enforcement, fire departments, EMAs. We've got 55% of the counties in Georgia that have been impacted by that program. That's a really big deal. We've pushed out a lot of Stop the Bleed kits, and we do have some good results that are coming out of that. As you all know, it can be difficult to track that information. People aren't always forthcoming for a variety of reasons. But we do know of, in the last 6 months, we've got 9 successful deployments of Stop the Bleed kits across the state. Two of those were in schools, one for a student, one for a staff member. The other 7 were with law enforcement. And I think that that's a really important component, is that that's been a dramatically successful program, is increasing that to law enforcement. We do have one officer that it was about 2 weeks after his Stop the Bleed class and that he received his trauma commission sponsored kit. He was assaulted, applied his own tourniquet, and saved his life. And he has been a supporter of our program ever since. Right. So hopefully we have some more engagement after he continues healing from that, and we'd like for him to continue to be an advocate for the program. Several other saves by law enforcement, to include some motor vehicle accidents, and of course, a couple of gunshot wounds that they were able to deploy tourniquets in the field. So very successful so far. I'm going to work to develop a little bit more of a streamlined reporting process, whether that's through our website or through the individual RTAC websites, so that we can get that information and hopefully continue to provide them with the resources for those that we know need it, access to the Stop the Bleed kits. 2 more things. We've got, we'll be doing our annual educational needs assessment. That's going to come up again soon. That's due at the end of March, I believe. So all of the pre-hospital agencies will begin to receive surveys on that. We hope that we'll have even more engagement than last year. None of this is designed to be punitive, but we're very heavily invested, of course, from the Trauma Commission and the RTACs in supporting EMS education initiatives. We just want to make sure that that's being spent effectively, and that if there are gaps that exist, that we can address those in a kind of just-in-time training. Oh, and the last thing is June 18th, we had our first virtual meeting for the RTAC chairs and coordinators, and we had really great participation from that. I think we only had one chair that was missing for some conflicting scheduling issues, but we also used the Mentimeter. Great conversation. I think we've got a lot of opportunities for sharing and collaborating across the RTACs. While all the regions look vastly different, there's a lot of opportunity for us to work together, share resources, especially with things like the blood projects. A lot of good collaborations that came out of that. One of our questions in that survey was, would you like to do this in person? And unanimously, everybody said yes. So we'll be meeting in person in February. I think it'll be another really good opportunity for engagement across the state. That's all I've got. But I'm happy to take any questions if you have them.
Crystal, the expanded Stop the Bleed for law enforcement, that's that graph up there, that picture. Up there,
That
right?
third map, now that includes also our fire departments, EMAs, but I would say probably 75% of that is our law enforcement partners.
And are you having any barriers, or did we just start this and that's why not the whole graph isn't red?
That's still our newest program at, I would say, about 18 months since we've had those applications open and really started to push out the training and kits.
Do you see any barriers in police departments accepting or
They are
jumping on board?
very accepting of the resources and the training. Region 8 has also received some additional requests for more training from law enforcement. They like the Stop the Bleed. They kind of want to take it a bit further. So they've asked for increased engagement, which is a great thing. Of course, from a EMS perspective, when we go into some of these violent scenes, of course, law enforcement goes in before we do to secure it. So ensuring that they can take those steps, that just a couple of minutes can make a really big difference, so that EMS has something to work with. And they've been very receptive.
Crystal, extraordinary work. My question is related to Stop the Bleed. 2,100 applications for new kits. What are you doing to get the messaging out that all these organizations know that these kits are available to receive?
That's a great question. So it's posted now on our social media accounts. Also, all of the individual RTAC coordinators, before these periods open and then through the duration of the month when the application is open, they're emailing all of their stakeholders and asking those to be disseminated. It's pretty effective so far. Yeah.
Crystal, great work. I mean, it's fun to see this continue to evolve and take off. So I appreciate your hard work. So really excited about the this, I guess I would call it saves, or what did you call, what phrase did you use?
Stop the Bleed saves, I think is what I'm calling it
Is
too.
that what you're calling it?
There might be a better term we can work on together.
Okay, so, we're gonna need that data, so be thinking now, because probably 6 months or a year from now, we're gonna wanna know, so, if we could, just keep that on your mind, or maybe we send out surveys. It's something, I don't say it like tomorrow, but we have to go offline, but I'm just planting a bug in your ear that, you know, it'd be nice to know, like, of all those red, you know, all the map for either the schools or the school buses, two separate things. You know, we sent out, you know, 1,000 schools, and, you know, 900 of them had a save in the first 6 months or the first year or something. It'd be nice to sort of know the impact, because we can take that data back as opposed to just, I know we have some anecdotal. So but is that possible? Can you, or
I
in the
think it
future, can we
is.
do that?
I'd like to have on the Stop the Bleed website, I'd like to have another tab just with applications that report use of your kit. So that'll help us collect additional information. And I think that one of the potential offerings that we have is if you report that you used your kit, one, we'd like the information, and two, we'd really like to replace it. I think that that would be ideal. One, we're keeping the kits in the hands of those most likely to use them, but also, to your point, we're able to collect the information on where and who and how, so that we can continue to have that level of impact.
That would be good if we could just, hardwire that to where that happens, but then at some point, we may need to like use your connections and identify a person to contact each place and send in, so just a very brief, something like, you know, when did you, well, we'll know when they started, but how many times have you used it? Have you had a save? And then we can set up a table or a pie graph and say, you know, we're spending this amount of money and we're getting this many lives saved, and we can put some value on that from a fiduciary standpoint.
I agree. I think I was speaking with Crystal Smith earlier this week, and she's obviously got a great Stop the Bleed program. But one of the really simple solutions she has is that she has a printed card with her information that goes in every Stop the Bleed kit that says, if you use this, let me know. I think that there's some really simple stuff that we can do.
That's really good.
It is,
Thank you. That's great.
of course.
Yeah,
Did you-
Crystal, and on top of that, I think just from a legislator standpoint, everybody's interested in their own district, right? So if we can, when we find out how many saves we have, if we could determine location, that would be helpful, because then we could get a, you know, a chart with dots and, you know, these are how many people that's got saved in your district, you know, that type of, I think that would go a long way. as well.
Right, and it's, of course, very
Absolutely.
difficult to quantify that, but I have been pulling some regional data on how many tourniquets are applied in the pre-hospital environment. You know, that not all of them are gonna come from our Stop the Bleed kits, but we do understand, at least anecdotally, that many of those are being applied before EMS arrives. So I think that there's multiple layers of information that we can begin to collect.
Go ahead.
So it'd be easy to do, like you just said, but just have a QR code and have the GGC logo all.
Just get that right.
Right, and it all goes into one spreadsheet that we kind of see a picture across the state.
The banker in the room is looking at, okay, how many kids, and how much a dog, okay. Do you need more money for more kids?
I
mean,
would like
your
more money for
budget is
more
not
kids.
endless that we have for this program, and it sounds like a very successful program. So in order to sustain that program, or certainly to be able to offer each kit used gets replaced with a new kit, I think we could use a budget proposal of what you think, what that would cost. Because we've been doing it as a one-time basis, and something more on the lines of sustainability at this point, I think is probably warranted. So if you could put something together and submit that to the Finance and Budget Committee, that would be great.
I think I've already got that saved. Ready to
I
go.
had a feeling you might have.
Thank you.
Okay. No, that is a great report, Crystal. Good work. We're getting ready to give you more work, so if you do a little good, we'll throw it at you. but- Yeah, I think, no, I got a lot of ideas. Okay. Where, I've lost track. Your favorite, okay, Dr. Maderos. would you-
For this, just remember that.
I asked for it, please proceed.
It is that wonderful time of year where we get to wow you with more numbers than you ever wanted to see. So that we can be very transparent in our process and all the details. And I also think it's really great that we're able to look at where the dollars are going, how they're supporting the different programs. You heard about a lot of successful programs already in such a short period of time since the kickoff of this meeting. So It's an exciting time. I am going to go slightly out of order because this is really going to be Katie's show. Even though I'm the one that sits up here and talks about it, it's really Katie and Gabby that do all the work behind the scenes. So it only makes sense that she go through her hard work and share with you all of the numbers. But on page 67 in your packets for commission members and those online, this is the only item that we need to vote on, so I thought we would dispense with that first for clarity, and then we can go through the closeout of the FY '24 budget. What you have before you there is a working draft of the FY '26 budget. I know it gets very confusing with all the numbers being thrown around, but this is something that we're required to do every year. As you heard Liz mention a few minutes ago, they're going to start the meetings with the agency heads. And so by September, we are required to submit a proposed draft working budget. It looks the same as you've seen in the past. It's the breakdown of the large buckets of expenditures. So I ask that you just take a few minutes, review this document, look it over, and then I will request a motion to approve, and then we can answer any questions.
Should I wait for the discussion portion of the?
Yes, sir,
Robert's rules?
you should wait for, or you can make a motion and then we can get to the discussion.
I make a motion to accept the budget as stated on page 67 of the packet.
Do we have a second?
Second.
Okay, it's open for discussion. So Jim, you may jump in with your vociferous discussion.
So with the budget, are there, I don't know, discretionary funds available for injury prevention efforts? Because injury prevention is currently not being funded at this point in time. If there were injury prevention projects that were to come up in various RTACs, would there be a possibility in the budget to fund those or not?
Because we have a much tighter control over the budget and the finances, and we do have the trust fund, we do have reserve funds that we've used the standard percentage to withhold. So we do, as a committee, as well as a full commission, have the ability to entertain proposals and requests throughout the year for additional expenditures. We anticipate this year, we know some are going to come up. And so we're trying to pre-plan a little bit for that, but the short answer to your question is yes. You're welcome.
Any other discussion? Good question, Jim. All right, hearing no other discussion, I'll call it to a vote. All those in favor of the budget subcommittee draft working budget on page 67, aye, in favor? Aye.
Aye.
Okay, any opposed? All right,
All right,
Madam Chair, it carries.
thank you, thank you. All right, I'm gonna now turn it over to Katie, and she can go over, starting on page 57 in your packets, the detailed closeout for FY '24.
All right, the first page that you're looking at, this is the FY '25 approved budget. It also shows FY '24 that we just closed out. The next document that you go on page 58 is the departmentalized budget. This breaks out each of the departments by each section and each line item. It's very detailed. Regina loves this report. Not going to go line by line, but if you have any questions, just let me know. It's 58 through 60.
It is helpful. I think
It is very
it's
helpful.
worth, yeah, it's worth looking at. We roll everything up and we do daily business with the roll up, but I do think it's good for everybody to see. Again, one of our biggest goals with the finance committee was transparency, and this way you could see each line item, how much is allocated, and then in each subsequent meeting, when we submit our budget reports and documents, you can see expense to budget. So you can see how much is being spent down in each category as well.
So Katie, this is where I embarrassed myself, given the fact that I'm on the budget subcommittee. Can you, obviously the Trauma Care Trust Fund is a super speeder, correct?
Yes, that is the super
What is
speeder.
the state general funds?
So that's made up of, I have this note on my desk at home. Okay, there's two different fees. So there's the super speeder reinstatement fee, which goes into the state funds.
Okay,
The super speeder revenue goes into the trust fund.
right, okay, so the 11,000,
So the reinstatement fee, I think, is the driver's license reinstatement when you lose your license and you have to pay $100 or whatever it is to
Right.
get it back. That's the reinstatement fee, and that's the one that so that's not the super speed, like just the fine for going
Correct.
fast. That's the reinstatement for the
That's
driver's.
right.
And that part goes into the general fund, right?
Yes, that goes into the reinstatement goes into general, trust fund is the super speeder
and
revenue.
then where's fireworks at?
That is not anywhere in this. That is actually allocated from the Department of Revenue now. It's a separate trust.
It's just, so we have two trusts.
Yes.
And so what,
Mhm.
Right, so just, I don't want to, this is a long meeting and I don't want to belabor it anymore, but so that 27,787, that's not including the fireworks. fund.
That does include
So
the
where's the
fireworks.
fireworks funding in? Is it the trust funds or is it the state funds? Or is it, there's another fund that's not on
No, it's in there now.
there? Okay,
It's this total right here, the 27,737, it's in there now.
okay,
It's allocated into the trust funds.
okay, great. Thank you, that's all I need. Thank you
Yes.
so much.
But definitely the general funds are not guaranteed.
That's correct.
so do we get that reinstatement fees that go into the general fund? Do we ever get that? Does that actually come back to us
Mhm.
in our trust? Put it in our trust.
Right.
So we are good. Okay.
Correction, though, the firework revenue is not on this document that you're looking at because we have not received that yet. It comes in around, it came in early last year and it came in February the year before and November last year. So it is not included in these numbers that you're looking
All
at
right,
here.
thank you. And then the last question, and I'll shut up, is. And then the last question is, where does the 5 million that or the 4 million that the state gave us as a one-time lump sum for the stabilization?
So that's added into the trauma center budget. So we do the allocation that we do the 80-20 split, and then we added that 4 million on top of the trauma centers.
And is that on this list?
That is on this list.
So next year, we're not guaranteed that, right, at all?
Correct. We're
So our
not
budget
guaranteed.
could drop.
Yes,
Okay,
that's
great.
correct.
Thank you.
It is not part of the 80-20 split. It goes directly to trauma centers.
You said that the Department of Revenue sends the money over for the trust fund.
Okay, so there are different trust funds. I won't get into the logistics of it, but there is a different trust fund for the fireworks. That goes into a separate bucket. It's not part of this allocation from the governor's office.
So what government department feeds the super speeder trust fund? Is it Department of Revenue?
That,
DDS. Okay. All right.
correct, that's correct. Yes, so just to clarify, the firework revenue comes in later on in the year. We make that part of the reallocation plan that you all vote on later on in the year. Because we don't know at this point.
And Jim, so that's some funds that potentially we would have to use for your injury prevention project or other good projects we have. Well, yeah, not yours, but the one you asked the question for, and I know that the foundation's looking to see, do we possibly have some opportunities for some matching funds? And that was, even though it had been removed out of the line item, because we talked about that at our meeting, and I didn't know where we had landed on that, but because we hadn't used it, we did take it off, knowing that we would have potentially some additional funds for that. Yeah. For the right project. That way it's not tied up in a line item we have to reallocate. We just have it to grant. Remember, Katie, we only got to page 3.
If there's no questions, I'm not going to go line by line on the departmentalized. But do look at your page 66. That is the trauma center allocation. Those are the new allocations for FY25 using the new formula. So just take a look at those numbers. We already voted on page 20 or 67, so we'll skip right over that one.
Katie, we will highlight, we did approve a new funding formula. I'm not going to go over that because we have a lot of numbers to go through, but I did want to draw to your attention the ability we had to increase the amount of funding provided to the rural level 3s and 4s.
On page 68, this starts out the budget closeout summary for FY24. This is the expense to budget report that is showed monthly or quarterly at the meetings, monthly at our budget committee meetings. And you will note on the pages of the reallocated funds that you all voted on in the May meeting, I believe, in the operations and the system development, those funds were reallocated to the EMS and the trauma centers, and you will see where those funds were reallocated. For EMS, we reallocated funds to the AVLS maintenance for 25, yes, for 25, and then AVLS airtime support. And then with trauma centers, we increased readiness. And we also did some one-time funding for unfunded centers, as well as increased the T-QUIP participation for all level 30s. Next, on page 74, it goes into the overall budget summary for FY24, and it shows each of the departments broken down into, I'll skip over that it shows each of the expenses, the categories, the percentage of the full budget to each of the expense categories. On page 77, we show the reallocated funds and where those funds were left over from that we reallocated. Same with the system development budget. We reallocated, as we always do each year, the RTAC purchase order reconciliation, where we leave a little bit of funds in there to get the new purchase orders established, as well as the Stop the Bleed coordinator position not needed, so we reallocated those funds. And like I mentioned before, we moved them into the EMS budget and the trauma center budget, and it shows we used it for AVLS maintenance and airtime. For FY24, the unspent funds, state funds, $229. That was what will be returned to the treasury. We did have remaining trust funds that we set up to pay out of the trust funds is the registry startup grants. So those funds will roll over. They don't go back to the treasury, and it's just have that project open.
Katie, I don't want to gloss over that. The fact that we only gave less than $1,000 back on a $27 million budget, it is phenomenal. So you need to be congratulated.
Well, thank you. Thank you. Oh, yeah, they don't like that we only returned $229. They tried to get me to leave $10,000 in there, and I said, oh, no, that's not gonna work.
Yeah, this is it's a little bit of a source of consternation. And, our funds, our stakeholder funds as mandated in 3111-102, we support trauma center and EMS readiness and uncompensated care. So as you guys know, we get real aggressive once it comes around reallocation time, looking, Katie always has her finger on the pulse, and just so you know, she runs QuickBooks in the background, because if we try to rely on that antiquated procurement system, it's really hard. I mean, it's nobody's fault. It's just the limitations of the system. So it causes some consternation, but we make it clear that our money is stakeholder money and it belongs doing the work that it was intended to do. So we just keep pushing forward.
Quiet celebration downstairs.
Yes. I know, and I have to stay on top of them too.
All the good stuff that we do with the money we spend is what
Yes. Yes. Page 82 starts the performance-based payment summary results for FY '24. On 83, it's just an overview of the split up between the percentages of each of the levels: 80% for level 1s and 2s, 60% for level 3s, 19% for level 4s, and 45% for burn. The next few slides go into the dollars at risk by criteria for FY '24, and you will see each of those listed out for each of the levels. And then on page 91, you will see that meeting attendance was the highest criteria not met, and this is what Liz was talking about, changing to a tiered distribution instead of all or nothing. We, like Liz said, we have heard loud and clear the complaints about and the obstacles that causes. So we're looking into that and making changes for FY '26. It will not be for FY '25, but it will be for FY '26.
I guess the question is, what are the challenges to making the meeting? Is it
It's
too onerous or too rigorous, or?
We lumped like the TMD, TPM administrator together. And now we kind of want to separate that out and then put, like, for example, administrator, you have 4 meetings, 1's in person, 3 virtual. Well, we don't want the meeting to cost you a cost that is, you just go, oh, I'll pass on that and I'll pay the money. I mean, because that's real. I mean, when we had peer review attendance, which I think we still do, requirements, people would just say, well, I'm not gonna have a 50% compliant peer review meeting attendance. It's not worth it. So we try to strike that, but at least then separate out so that if there's one person that's not compliant of the quadrat or whatever, exactly, yeah. Mhm.
The next is the open purchase order summary. This lists out the open purchase orders. It is much cleaner. There are still a few that are older purchase orders that we're working to clear up, and the notes and the explanations are on the last column. You will see quite a few of these or the first 3 are from 2020. Those will be closed out by the end of this calendar year, not fiscal year, calendar year. But then there's some others from 21, 22 that are projects, Arbormetrics, March Pause. And then the others are just, like I said, the notes are over to the side. I'm not going to go line by line, but most of them will be closed either by the calendar year 24 or the fiscal year 25.
Just to pause for a minute. Is there any questions on that? The reason we hone in on that is because they're what we consider dollars at risk, because OPB can come in if they don't see activity on a purchase order, they can just close it and then the money goes back to the treasury unless the purchase order was written on commission funds. And Katie tries to be very strategic about how she encumbers funds now to make sure that the ones we know are going to go out the door, like trauma center funds, those are treasury funds, and other funds that might be a little less reliable, we would be trust funds so that we can, re-encumber. it's like I planted you in here for that question, Dr. Smith. We worked with OPB because for the Arbormetrics project, that is our, that was a big investment for the commission, 1.5 million launch into the risk adjusted space. And we knew that that was going to be a 3-year project, and we didn't want to pay the startup fees, which were 334,000, and the first year subscription, and have like an over $500,000 investment, and then say, oof, we can't fund this anymore because we lost money or whatever. So we encumbered the money for 3 years worth of it up front, because it's a pilot essentially, and we're gonna do like a postmortem on it to see like, is this working, and we worked with OPB on that. So they know that, and it does get an invoice that hits it yearly so it's got activity on it. The ones that are really at risk are the ones that don't have activity on them.
You can see the older ones, are the ones that have the account.
Right, the next slides we move into are the super speeder revenue. That is on page 94 in your packet. The first one shows the revenue to budget comparison. We do not get a amended budget anymore due to super speeder. We get everything up front, so that amended line you will see no longer move, but at this time it's still on there to show just from prior year. The next slide is your 23 to 24 comparison. Yes. Well, just remember, these funds are based on when they are actually paid. Yes.
Well, thank you for all those who paid it.
Yes.
They got
Yes.
their tax check.
All right, and then the next is, it's also a 23-24 comparison. It shows the percentage that we're up. We're at 5%.
The first year, our percentage has been in the green every month.
Yes.
Hate to say it.
Right, and then we've also started including the trust fund statement in your packets. This is just for review reference. So how this works is the Department of Public Health takes out withdrawals to cover our expenses. So that's what, when you see withdrawal, that's from the Department of Public Health to allocate to our budget. That's a good question. We do not know, but I could probably find out.
Georgia residents versus people traveling through the state.
I can find that out for you.
She's got a friend.
Yes, fauna friend. Yes. And that wraps up everything unless there's any questions.
Thank you, Katie. Dr. Ashley, we tried to make this a little more concise so you didn't get too glossed over before, but did want to have a comprehensive review of last year's budget and the closeout, so everybody's aware of where we are, where we began. Are there any questions?
In 2 years. Mhm. Yes. Mhm. Every year. Thank you.
Any other questions on the budget documents? Thanks, Katie. Turn it back to you, Chair.
All right, we'll move into the EMS committee report. You know, who's given that today?
Did-
Oh,
Okay,
Terry,
so Terry, you'll do the report, and then we have Natalie Lee from the Geospatial Office to go over those educational maps, okay?
So, I'm just gonna have to read the report. This is a report he prepared, it's kind of last minute, but subcommittee reviewed the spending plan, remove monies from the public information project. These funds were used to increase the number of mental health classes to 10, which is 1 per EMS region, and increase the funding for the EMT and advanced EMT classes. We're working on an educational platform to provide testing for the classes that we support. Each class will be required to utilize the testing module. Test will monitor these scores to identify programs with difficulty early on. So as we put out the EMT classes, this is a module that all the classes are required to use as a part of receiving the grant funds. We have added ability for each service to request temperature probes to monitor temperature in their units. These probes will automatically connect to the AVLS systems that provide alerts when temperature goes above a set level. They can be used for blood storage, medication storage, or both. These devices are provided at no cost to the service. EMS equipment grants, we continue to examine this funding to ensure that it meets the needs of trauma patients and is distributed appropriately. Inter-hospital transportation, we've received some data from the study provided by the State Office of Rural Health and Mercer Rural Innovation Center. These results are available. We'll work to focus on areas with specific issues to determine needs. We've also received information that the next legislative session may provide the funding for the transportation study. EMS recruitment tool's been finished. We've had a formal report on it. Does appear to be successful at this point. The next part of that project has not been funded. We'll review how this project will be funded going forward. And Mr. Atkins is working with the governor's office and DOT to evaluate the placement of blue hospital signs, which are designated to help motorists find the nearest hospital. That concludes the EMS committee report. Any questions?
If you want to come up, yes, perfect. And you probably have to press the little push button on your thing to speak. Okay. It lights up a little brighter.
Yep,
There you
it's
go.
brighter, okay. Good morning. So my name is Natalie Lee. I'm the Deputy Geospatial Information Officer for the state of Georgia. I have had the pleasure of working with Liz and the team on preparing some maps for you guys to see where courses are being held in the state and where individuals are attending those courses. So I believe in your packets, you have a set of PDFs. It might be a little bit awkward to kind of go through them because I'm going to kind of say the same thing on each one of them. The way that the maps were created, when people do their registrations, we gather information about their home address, their professional work address, and then information that we have on the training, the course training itself. And then what we're able to do with spatial data is we're able to map those things and then create a drive time analysis. And that says, okay, given where people are and where the courses are, how long does it take to get to one of these courses? And then we can kind of see based on the map where people are driving a long time to reach the course and where they're not driving as far. So that can help to inform you all on where you want to host those courses and where you might want to do targeted outreach. So a couple of things I wanted to mention. Last year, the way that the registrations were done required quite a bit of massaging of the data afterwards. So sometimes when you have someone register and they put in their own information, they're not as careful about their address and what they put in on what course they're attending or times. And so some of that information was massaged. That also means that on some of these maps, you're going to see where we've left off a couple of the individuals because we weren't able to be confident about where they were coming from. In other cases, we would assign the location to their home address because we did not have a work address for them, and vice versa. So I guess we'll start with auto extrication courses. I think that's the first one that you have in your packet. And what I think it might make sense to do is just go over the template that we used. So individuals are on these maps, the location maps are in that navy blue color. And then to make it a little bit easier for you to conceive of where these courses were being held, you'll see both a yellow marker of the actual location of where the course was held, and then you'll see a shading on the county that indicates the general county and where that was held. So a little easier for you to kind of gauge with your eye where things were being done. And then you'll see some statistics up there at the top about the number of students enrolled. If you don't want to do the math of counting on your own, which I would not. And then an indication of how many completed the course and then how many contact hours were issued. I'm very grateful to the team for reviewing those statistics on each of these maps. So the first is auto extrication. And then we can go to the next one. So axioms of leadership. And the next one, EMS instructor courses. The next, EMR courses. Okay, this is a pretty busy one. This is EMT courses. And if you go back, I'm so sorry, I should have said, if you go back, there is a special note on this one that, again, just massaging the data and getting an idea of initial registrations for both EMR and EMT were combined. All of them didn't complete the course, so just putting a little bit of a caveat on that map. So we can go to the next one, sorry about that. Okay, so now we get into those travel time maps. So when we do travel time, the kind of buckets of time that we used were half an hour, 2 hours, or 2 hour plus, so like 3 hour plus time. So you can see in there kind of varies for each one of the course. Each of those polygons is going to look a little bit different just depending on where it is. It's also interesting to note that there are some geographic impediments to drive time. So you're going to see that too, some kind of squirrely looking polygons. That's just because of how people are accessing the infrastructure to drive to those courses. So this is EMR, EMT. You can go to the next one. So what we did on this map is just to make it easier for you to kind of differentiate between EMR and EMT courses. So that's why there's different colors. We can go to the next one. Okay, so now we're back to some of the location maps for farm medic. So each one of these were not given drive time analysis, so you won't see them for every single map. Okay, go to the next one. So this is drive time to those. Can go ahead and head to the next one. So this is a map that shows the leadership program courses, and then we show that on top of the regions. We thought that would be helpful so that you could get an idea of representation from each one of those regions to that leadership course. You can go to the next one. Lodge course. A lot of people traveling outside of Glenn to get to Glenn where the course was held. You can go to the next one. And this is any NAEMT courses. So you'll see we broke those up so you can kind of see each individual course is a compilation of courses. So we have them broken down in those different colors so you can differentiate between them. Go to the next one. This is drive time to those courses. You can go to the next one. This is TECC, Tactical Emergency Casualty Care courses. You'll notice that TECC courses were also included, I think, in NAEMT courses. You can go to the next one on that one too. So this is another drive time for that one. And in here, just to make it a little easier to see, we changed the course registrants to white. Try to make them show up a little bit better. So we can go to the next one. And then we have Trauma Skills Lab. It's very well attended. And let's go to the next one. You can see quite a concentration in the greater Atlanta area. We can go to the next one. And then this is just a big old map showing you every course that was held and all of the students attending. So you can see an overall picture of your outreach activity for training. Okay, I think that might be the last one. Okay. So I mentioned before that a lot of the data that we used to create this was scrubbed from Excel sheets. So our recommendation is that an option for you going forward is to use a QR code for a survey 123, which is something that we use all the time for GIS data for analysis. So it allows us to geo-enable the data when it comes in rather than kind of scrubbing it on the back end. It also means that you can look at where people are registering on the fly. So if people are registering for a course that's 2 or 3 months out, you would be able to see if it was not very well attended. You could do outreach activities to try to bolster the number of registrants in that area. So you'll see in here, you all could register for this right now. This is our trial, our template of what it would look like and feel like. So the QR code that was shown on the screen before, that's live, so you guys could try it. But if you can kind of go forward, it explains why we're collecting information. It allows them to kind of start typing in, and it validates their entry. So make sure that the data that you get is clean, especially their geospatial information like their home address and work address. So if you want to go forward, you can, yeah, so she's just gonna, it remember, just like most forms, it remembers whatever you typically use for an online form. And these are able to be used offline. So if you download it on a machine and have it online, somebody shows up to a course and wants to register on the spot, that's possible. Okay, you can go forward. I love it. Okay. So again, these are the statistics that were gathered from the existing registration. That's where I got these from. That's probably my fault, so you can skip it. It won't. Yep. All right, so anyway, at any rate, this is a template example of what it looks like and what it would feel like. And then at the conclusion, when she submits her registration, it would send her a follow-up email that gives her more detailed information, and then it logs it on the back end so that anyone can communicate with that registrant. So I think, Liz, if there's anything else that you think I might have left out, that's it for today.
I know we can't demo it right now, but I loved your live feed. Like if we use their survey 123 capability, theoretically, at the time a course is being held and people are walking in and QR coding in, you could like see active where you could see like almost immediately where courses are happening.
Yeah.
That'd be really powerful. In addition, I think the power, and Terry, please comment on this, is that cumulatively, now that we're starting this, if we look at it over time, I know that not every area in the state has the ability or the facilities to house some of these courses that have requirements that you have to have in order to be able to put a course on. But we can really start to see the gaps and figure out where we need to bring courses to. So, and I think the EMS committee is working on some selection process criteria for courses, et cetera. Anything else to add?
Okay, any other questions?
Yeah, thanks very much. I was never a big believer in heat map analysis, but this allows us to get it. It collates the data in a very easable, visible way, and you can figure out what the issue is in a very short amount of time. So I'm becoming a believer in geospatial mapping analysis. One question I did have for EMS though is, besides the trauma skills lab, the report back, the feedback that we get is that education, especially with EMS, is really sought after and really wanted throughout the state. But I'm a little disappointed in the number of people that actually attended courses. over a 2-year period, only 3,000 people attended. Now, and the vast majority of those people, half those people attended a trauma skills lab, which for us is fantastic. But the reality of the situation is we need more EMTs, we need more paramedics. So those courses really should be the crux of where this education is taking place. Leadership courses are fantastic. I don't want to downplay those, but from your standpoint as an EMS provider, is that a good number, 3,000, or is that a disappointing number, 3,000?
I don't know that I could answer that because I'm not an educator, so I'm not used to looking at educational numbers. You're absolutely right. The EMT classes, I think, are hugely important to us trying to bolster our staffing around the state. I think the other classes are well received, but to make a comparison in numbers, I don't think I can do that.
Do you have any idea offhand how many EMT providers there are in the state?
I don't right offhand.
I'll throw a number out there. Whether it's EMT or paramedics, but the number that I've heard is like 29,000. I don't know if I'm off or on with that. Maybe our colleagues from OMS&T might have a better number, but I've heard that number in the past. I don't know if that's true or not, but and I don't know if that's a lot or a little. Is that a good number or a bad number, or low number? Okay, so we're short, in other words, EMS providers.
Wow.
So when you say distribution, you mean the workforce is not necessarily actually in EMS, they're in, so we are not so much geographic, but just the whole thing. We don't have enough people in the paramedic field. Correct. Working in the paramedic field. Okay. So I think, Natalie, number one, I think this is incredible. So thank you for your work. This is phenomenal.
My
And
pleasure.
I think you hit the nail right on the head and went above the call of duty. So very, very nice work. And I want to keep working with you in the future. But I think as I look at this is really important for EMS. It may have been a little painful to get here. People having to do a lot of work and look at sheets, and I'm sure Liz dogged people to get the work done or whatever, but this is huge for the commission and for EMS, because if we don't know what we don't know, we can't help EMS. And so that's why I'm asking questions. And when you look at this and you look at the first thing legislators want to know is, are you helping just one county or are you helping the state? And unless you're talking to the person in that particular district, they want to know about their district. So now we can answer some of those questions. And this is, I think, a success story, is the commission has invested funds in EMS over the years. This is impressive of all the places that we've touched. And it's not just Atlanta or South Georgia or North Georgia, it's everywhere. So this is incredible data for EMS to go out and say, we need more funds because we're spending it in the appropriate way. So I just see this as the foundation to help EMS get to the next level. And I don't have a magic wand to figure out how to get more people, move that 40% that Michael's talking about into the 100%, get them out of the hospital into the field. But I do know the commission can make sure that the people in the field have access to education, and we want them to have, and that's part of our mission. So this helps us do that. And so I'm going to count on you, Terry and Courtney, to take this and take it to the EMS subcommittee and go to the next level. Okay, how do we get these folks what they need? And if we need more funding, we go for more funding. So anyway, I just see this as a great foundation, and I'm going to count on Natalie and our EMS subcommittee to go to the brainstorm and go to the next level.
Yeah, there's a lot of next levels with this data for sure. And I think one of them is barriers to education. If we've got 5% of the available people only attending any educational course, why is that? Is that because they're so busy driving a truck that they can't attend an education course? Or is it the course isn't close to them, or what the issue is? I don't know how to develop a survey for the entire state. This brings up a lot of questions, which is fantastic, right? So we've got a lot of directions we can move with this data for sure. So thank you so much.
My pleasure.
And Terry, I would ask you all to take one thing back, you know, your list is getting longer, having more commission meetings, but you know, and what we found out the hard way through many years of from top down, going from grassroots up. Now that you've got this data and you can show your 26,000 folks, this is what we've been doing, you know, show them and ask them, is this what you want? I mean, are these the courses you want? These are we missing a gap? You know, I mean, you and Courtney have a lot of wisdom and educating, you know, but they may need something that the EMS subcommittee doesn't know about. So just put a feeler out there and see, are we providing what they want? And just make sure that you're on the right course, you know.
Discuss that, and I think we do have a plan going forward. So that is part of our discussions that we've had at the recent meetings.
And just.
I'd just like to add that the RTAC coordinators are doing that educational needs assessment, and we'd really like to work with the subcommittee to kind of share that data and help to develop the needs of the courses.
That may be the best way to do it.
RTAX and EMS subcommittee should be joined together on this education project. I mean, you shouldn't work in silos, so I don't think there's attend each other's meetings, or at least you two talk, you both.
I think we've been doing a report out, but I think that we can work a little bit better to maybe develop the survey tool that the RTAC coordinators are sending out anyways, and then hopefully leverage the subcommittee to help us get those surveys completed.
Yeah.
And I think that's one thing I was gonna say is, I mean, I guess what courses are wanted and how we figure that out, and then where the locations in the state where they might be, because you can see some gaps in certain areas, and maybe we're not offering the courses in the right locations. And their question is, if I was a provider, how would I find out where, is there like a central place I can go to find out all the courses currently being offered, or how's that work?
Yeah, so we contract GEMSA to teach most of the courses. So GEMSA's website, they can go there and scroll through and step in here, Crystal, because I'm not an educator.
Yeah, and GEMSA sends those out, those emails about course offerings. Usually that's to the member list, but that's something else that we'd like to engage the RTAC coordinators to do is when we receive those, we know about courses in our region. They have a separate distribution list that maybe we can have a little bit wider participation in those classes.
To take this to honors level, as you usually say, since we have all the academic centers here, it seems like, and I think there are 2 EM residency programs in the state, if I'm not mistaken. Is there some way we could get some academic bolstering behind this to take this on as it feels like this would be more in the realm of EM versus, I mean, we've already got 5 trauma projects lined up but it feels like this might be meaty for someone who needs, I don't know if those programs, like if the fellowships have needs to have, you know, projects like this.
Our EMS fellows are already linked in and working with our RTAC on some of that education stuff. So that might be another opportunity where it's a little harder, I think, because there's, you know, just the 2 to get engaged more globally, but certainly they're actively involved, both in our hospital PI to design education around PI issues identified from field, as well as with our RTAC, because RTAC is more broad reaching across all the counties. So ours is tied in there. I don't know if Region 3's is tied in with your RTAC, but that's.
Now we have so much data, right? And we're about to have a whole other year worth of it dumped on us. And then if we get the survey 1, 2, 3 linked up, we'll start getting real-time data. It seems like this would be something that somebody could take and manipulate and come up with something, a really good story to show and to publish on.
I hope it's okay to share that we can also enrich the data. So there's living atlas information that we can enrich with census information. So we could even pull numbers of where we think the target demographics are for some of these courses too. We can overlay that, do some analysis.
That'd be really good. tying the census data into where the needs might be, because then we can identify gaps.
Yeah, and a step further is we can also pull some of the data that Gina's getting to identify what training needs do we have. I think there's always been a gap in what providers request for courses versus maybe what's necessary based on the calls that they're seeing and things like that. So I think a lot of opportunity to continue the data. We also are going to work with University of Georgia with a NPH student, and this might be an opportunity for us to bring them in and help with some of that analysis.
As our tax PI process is getting more robust, they're spending a lot more time looking at microsystem level issues in the pre-hospital area that they can target education on to enhance the pre-hospital care in a positive way, not, just trends that we're seeing and how can we help support you. And they've been very receptive to that. Even across state lines in South Carolina, we've been invited out and we've done some simulations with them on stuff, and it's been very positive, and we're seeing a positive result in the resuscitation room.
How about if we utilize the RTACs to do a survey within their own district, just to try to get some idea of the shortages that are out there, necessarily perceived, but actual shortages of medics, EMTs, et cetera.
I think that's a great idea. And we've kind of been working on the idea, the way the surveys will work this year. And my thought is that we have one survey that goes to EMS directors. So what are your pinch points, your needs? Is it training equipment? Is it capable instructors? What is it that you need necessarily? And I think that we can include workforce data in that. Another survey was going to go to our educators with what are your pinch points? Are we having difficulty in enrolling students? Are we having difficulty with again, capable instructors or credentialed instructors? How can we impact that? And then a third survey that goes to the providers. What do you see? What do you need? What can we teach you? That was kind of the thought that hopefully we get a pretty large data pool to figure out how we can best utilize the funding and where we can target additional classes.
Great suggestion.
That's a great suggestion, Pete, and I think Crystal, Crystal. I'm just having a little coffee is fading. I need another cup. Is on that. So could I, from hearing the discussion, it sounds like there's a lot of energy here, and there's a lot of ideas that just need to really be sort of refined. Thank you, Jim. That was a great word. Refined. Could I be so bold to ask Regina and Rob and Crystal and Natalie and Terry and Courtney. Maybe I should just ask Courtney. He's not here. You don't have to ask. Yeah, that's right. Just voluntold. Could I ask you guys to pull together a Zoom call or something over the next little bit and really just develop these ideas into some kind of plan, like for the next year? Because I really, if we just leave here today, it's not going to happen. And I know you all are busy, but I really think probably we'll do one more call and just refine the ideas, how we want to do this, and come back for the next, our plan would be for the next commission meeting to really present, this is what we think we need to do, and to pull all these ideas together. Because I really think we can do something very nice for the state education-wise for our EMS colleagues, and we can be academically productive for our programs that need to publish. I think it's a win for everybody. And so is that fair? This meeting's being recorded. The lady tells me so. I know you all said yes. So it's fine.
Just one question. Is there a way to look at what the states surrounding us offer? Because some of our gaps on those time distances are on the fringes of the state. Do we know what they offer in South Carolina and Alabama and Florida to fill those gaps out of curiosity?
That's a great question. I have no idea, but I can find out for you.
I think it'd be interesting to see if the gaps are actually filled.
I do know that what we do in the state is pretty unique. The
We travel across, do a lot of education.
Yeah, my suspicion is that people from South Carolina are coming to Georgia to get their education, and it's, they're getting their courses met by us, not by us meeting theirs.
That'd also be interesting to know. I mean, how much support we're providing outside of the state. If that's the case.
Okay, Natalie, thanks for your report. We'll move into the level 3, level 4 Rural Trauma Center Committee report, and I guess that'll probably be Dr. Greg Patterson. Is he on? Or is it Alicia, Dr. Register today?
Hey, good morning, everyone. Can y'all hear me fine?
And you're perfect. Go right ahead.
Wonderful. So with Courtney's absence, I'll just touch on March pause. We are trying to organize the best way to present the PowerPoint kind of didactic portion. So there's still discussion and kind of organizing the logistics of that. Next, the rural and non-trauma resources demographic survey that's been mentioned a couple times earlier in the meeting. We had a really good return on that survey. A lot of thanks to Nita Ham for that. And it gave us some good data and insight into where the gaps and challenges and opportunities for improvement in our trauma patient care. This survey was not only sent out to trauma centers, but was sent out to all facilities that have ERs in rural areas. And so that was very helpful to see the response difference between already designated trauma centers and non-designated centers that are providing trauma care. So I think there's going to be a lot of good results from that survey. Our plan, I think Liz mentioned this earlier, was that we were going to put together a webinar to send this information out, but more is to come from that project. Next is our level 3-4 PI process and mentorship group. They meet monthly, and basically the purpose of this group is to share what all the centers have learned from their ACS consult visits. And so it's very helpful because, like you said, Dr. Ashley, there's no point in working in silos. And so this really helps us work together and share as much information as possible so everyone can have success with these ACS visits. I do not have anything to bring forward as far as asks or requests or issues. So I think that concludes my report. If anyone has anything to add on that or any questions.
I think that's great, Alicia. Thanks for that report. And, I think that your committee continues to do great things and really represent rural Georgia. So we're sort of really counting on your committee to keep up the good work. I'll just, on the March pause things, we had some discussion on that earlier about the purchase order still being open from previous years. And so just, I think just take back to your committee. I know Courtney and Greg maybe talking or working on that some, probably you as well. So just keep pushing on that. Let's try to get March pause, over the next couple of months or so. Let's just get that to the finish line. I think that would be the only request from the commission. But otherwise, I think we're doing great.
Yes, sir. Thank you.
All right. Thanks, Alicia. Appreciate it.
Mhm.
Okay, we'll move now into the Georgia Committee for Trauma Excellence report. Tracy Johns.
Good morning. This is Lenore, not Tracy. Surprise. So our pediatric subcommittee, they are collaborating with the centers to provide additional information and resources on the.
Tracy, you sound like you're underwater. I'm not sure what the technical problem is, but we can't really hear you.
Sorry about that. Is this any better?
Not really.
No. How about now?
That's better.
Okay, sorry about that. I'll just start off in case you couldn't hear me. The pediatric subcommittee, they are collaborating with various centers to provide additional information and resources on the SIPA education, and integrating it into the EMS trauma symposium talks as well. The pediatric transfer toolkit is still under development. Various centers and combining the best elements, and they hope to have a first draft of that.
And technical difficulties here. It sounds like you're underwater.
I apologize. I'm not exactly sure what to do about that.
That was, right there was a little better, maybe. I don't know if you're too close to the mic or too far away, or.
Okay, how about now?
That's a little better.
I apologize. The Injury Prevention and Outreach Subcommittee, Carrie Page, the TPM for Memorial Health Meadows, is accepted to be co-chair of that committee along with Crystal Smith. They provided the Georgia Trauma Systems National Stop the Bleed Day webinar on May 23rd, which was very successful. They had over 300 participants. They just completed the back to school training blitz for Stop the Bleed, and they had over 1,500 registrants for that, which is very successful. And then in June, they had the Georgia Stay Safe program, which focuses on preventing pediatric firearm injuries. They held a webinar with over 40 attendees to that webinar. And they're gearing up for the Georgia Falls Free Fridays for Fall Prevention Month in September. And these webinars will take place on Fridays in September at 10 a.m. The Education Subcommittee completed their first draft of the Trauma Program Manager Toolkit. It's been sent to the stakeholders for their initial review, and this toolkit is really phenomenal. They did a lot of work. There's tons of resources, lots of information, which will be very, very helpful for our new trauma program managers coming on board. And they hope to disseminate that toolkit to everyone by October the 1st. They're still working on the Essential Trauma Nursing Skills Project, which will guide and support nurses in non-trauma centers. They're creating a poster and PowerPoint presentation that will be concise and easily accessible for quick reference and minimal training for these facilities. And they hope to have that completed by November the 1st. The Performance Improvement Subcommittee, they're continuing to standardize the statewide time to definitive care. They're determining timeframes for emergent and urgent transfers, as well as defining criteria for categorizing the transfers as emergent, urgent, or non-urgent. And they hope to have input from the TMD group on this project. And then finally, the Registry Subcommittee group, they reviewed the required education for all registrars that includes the new TQIP module and at least 50% of the TQIP monthly education experiences. And they are in the process of establishing a registration process in order to hold the virtual AIS 15 course update, because the AIS 15 will go live on January 1st of 25. And that was all I had. Sorry for the y'all not being able to hear me well, but I'm open to any questions if you have any.
Okay, thank you, Lynn. Any questions for Lynn? All right, thank you. Thanks for all you do. We appreciate you. Where is that? Hold on, Lynn.
Lynn, were you going to bring forth the request for funding to print the pediatric transfer toolkit?
Oh, yeah, sorry, I forget. Yes, Tracy did want me to bring that. If there would be any funding available to print that for the centers, as well as the poster to disseminate to the non-trauma facilities when it was completed.
Do you have a proposal? How many, what the cost will be, anything like that?
No, she did not give me our money.
This will be easy then. We would ask that you together the dollar amount, the distribution, and the cost for us to review.
Okay.
And just a comment, I did have a chance to look over the program manager toolkit. It is really phenomenal. That was a great job. That committee's done a lot of work. It's very, very comprehensive.
That's great.
Lynn, this is Dr. Doug. I think we may be able to help at least give you some preliminary data on the time to definitive care. Dr. Ashley and I have been working with our two centers, and I'll share this more in the systems performance group. But I think we might be able to answer the goal time, at least what it's taking for patients to get, to transfer out of our facility. We have that data now on at least 1,800 patients, between Region 5 and Region 9. And then based on ISS, we could potentially figure out emergent versus urgent, but I'll leave that to the TMD group to further define that. But, if they're activated as a level 1, they're probably emergent, but, at least we can give you some preliminary data based on ISS about how long it's taking people to leave the outside facility. I don't know if that'll be helpful or not, but.
Yes, I think that would be very helpful.
I think we're trying to identify a target goal. What's our benchmark time? Because we're doing a little, like you guys are doing your two centers, all the Wellstar facilities are looking at that as well. Preliminarily, we're finding acceptance time is quick. It's just getting the patients moved from center to center has been an issue. But again, nobody has a clear definition. A level 1 may or may not be, it could be a time sensitive injury once they get stabilized. So the TMDs definitely, how do we define critical patients or time sensitive patients? And then what is your benchmark for those patients? And what is your benchmark for non-critical patients who need specialty services not available? Those are the two. If we could come up with a consensus definition for those, then as our RTAC start looking at this data, GCTE starts looking at it, and like our system, the Wellstar system's looking at it, we're all comparing apples to apples. We can combine our data together. But right now, I think we're all operating on different ideas and different definitions.
I think that's great, Regina. Thanks for sharing that with us, because Jim and I and our teams, kudos. They're just doing an incredible amount of, you can't believe the amount of work they're doing on this. And we're going to have real data for you soon where you can answer something, and that'll be a discussion, because we'll finally have data to say, this is how long it takes to get here from, we know the data from the ditch to the first hospital to the the final trauma center. And where any delays are along the line, we'll know their ISS scores, we'll know the length of stay, we'll know their comorbidities, we will know their mechanism of injury, we will know for chest injuries, for abdominal injuries, for head injuries, or combinations of the above, if a delay or time was associated with outcomes. We'll have all that data within, maybe by the next commission meeting.
That's the goal, yeah, at least to get a rough draft of 30,000 foot view of it. We obviously want to publish this data. So we'll be refining the data and further analysis, but we should have a first draft analysis by November. That would be the goal.
So where that will come in for what you're working on, we'll be able to say, okay, here's the data. Let's everybody look at it. What is the time? Is it 2 hours? Is it 3 hours? You know, should we say, should the state standard be, we're going to shoot for 3 hours for these type, even maybe different injuries or things, because we don't want for a thumb fracture, everybody sounding the alarm and taking our one ambulance in the county and running with lights and sirens to the truck. So we'll accept 8 hours on that. But for a gunshot wound to the chest, we're not going to accept 8 hours. We want an hour, and EMS needs to know that. You see, so I think this will be the foundation of where then let the game begin. Let everybody talk and come up with it, and then maybe there's a new standard that we look and we track, and then maybe that becomes a whatever, you know, in whichever committee that affects. So I think your committee will have some data that you can actually say, what should we do? Why don't can you get with, who should you get with? You really need our template, because we've got it lined out with the exact time points. And if you follow our template and our tables and collect that data, then the data just builds, because it's pretty thorough.
Yeah, we can compare apples to apples instead of apples to kumquats, you know.
And I guess I guess with either Tracy or
Nina.
You know, basically what all you need is just
Is the spreadsheet. That's all
of
she
what
needs,
data
yeah.
points do you collect?
Yeah.
And you can have that.
I can forward that to you.
We would love for you to use it.
Yeah, I'll be sharing a little bit. I think I just shared my systems committee report right now, but it's not, that spreadsheet is not, no. But while I'm here, in case I forget to give the shout out, I want to give a shout out to DPH and the state office. You guys have been instrumental in giving us the first trip or sheet reports from scene to first hospital. That's been the biggest black hole for us, for both Dr. Ashley and myself. And you guys have been instrumental in helping us track down that data. I think what we've learned from this process is that we got to somehow refine the system, because the individual trauma centers don't have access to that data, or they can't pull it, whether it's a misspelled name or a wrong birth date or whatever. But we're gonna have to try to figure out if we can improve that process to improve that data collection, because even you guys are having trouble pulling that data and linking things to but thanks so much. We could not have accomplished what we've accomplished so far without DPH's help, for sure. Thank you.
Okay, we'll move then into the rehabilitation committee.
All right. Hey, everybody. Can you hear me all right?
We can hear you. Go right ahead.
Okay. Yeah, this is Dr. Vox reporting for the rehab committee. And thanks to the commissioners for approving some funding for data scientist time. As you know, we've gotten Dr. Anderson on board, who I believe has spoken with you before, and she's been able to start to dig into the data. And on our last committee meeting, we were able to start looking at that and parsing things out. One challenge is certainly refining, the precise diagnosis codes and groups and so forth. But we're able to already start to do a lot of interesting geographical statistical modeling, and are going to be correlating some of the discharge locations with the different trauma centers and where folks go and so forth, and start digging into some of these questions that the ACS wants us to. I do have Dr. Anderson on the line here as well. I sent her my link, so it looks like she's under my name there, but she can chime in as well and add a little bit more color for the commissioners. You might be on mute. Can you unmute your computer?
Is this better?
Yes. Yeah, we got you now.
Apologies. I'm working from a different location at Shepherd to try to actually fix somebody's dashboard. So in a different study. So I just wanted to take a moment and say thank you all so much for getting me the data. It's in much better shape than anticipated. And so we were able to get very quickly into the data and start mapping it out. And so what we have already done is analysis on demographics, geospatial location of the injury location, the time that they were in the hospital, including some more detailed information like days in the ICU, days on the vent as relevant, and discharge location. And then with some really great insights and guidance from the rehabilitation committee, we've identified subgroups for analysis. And so the plan moving forward in the short term is to take that overall analysis on things like patient demographics, patient general information, their hospital experience at a very high level, but with some key details, and then the rehabilitation discharge to do that by subgroup analysis, not only by type, but some other key demographics that were identified by the group. So I think we had a hyper productive meeting in no small way because the data were in much better shape than I anticipated. And so I was able to get a lot further, much quicker as soon as the data were released to me. So we're in very good shape. I don't want to say we're ahead of schedule because that's always the kiss of death when it comes to data, but we're in really good place. And I would love to answer any questions you may have or have any suggestions you may have that we can take into account as well.
Any questions?
just one, and this may be facility specific. But do you guys have a sense of how many facilities have access to a physiatrist? Or whether it be a consultative service or a employed physiatrist to start the rehab process? Because, you know, obviously, as we all know, rehab starts from admission. But if we don't have a solid plan in place, they come to you in a lot worse shape than they may necessarily need to have been. Do you have any sense on that statewide on the availability of physiatrists?
I can only speak to that from my experience receiving patients into rehabilitation from throughout the state of Georgia, you know, for the past 12 years. My experience that it's the minority, you know, I would say maybe less than 1 in 4 are coming in with evidence of a prior physiatry consultation, really probably less than that. We know who the primary centers are that have those departments, you know, Wellstar and Grady principally, and then it's a little bit more hit or miss at some of the others. That is not something that we have, you know, kind of started to tackle per se on the committee. We've started to make some headway with regards to this survey on the rehabilitation resource perceptions and so forth, and can add those questions to that since it's simply kind of a fact-finding type of thing. Agree that would be ideal if we had more rehabilitation physician involvement at that consultative level. It really depends on whether that individual trauma center has an inpatient rehab unit of its own, in which case they would have that staff able to go over and do those consults. And of course, many do not.
Thanks.
While Dr. Vox was talking, I did a quick search through the data and I don't see an indicator for it. That doesn't mean that it doesn't exist in the data. It means that it is not hyper clearly labeled to a way that I could find it in 30 seconds. But I made a note, and then I also made a note as Dr. Vox was talking about Wellstar and Grady to see if I'll look into their data and do more of a language analysis to determine if that comes up. And if so, then we can figure out what indicator it exists. We can test it from there. So the short answer now is probably potentially no. I don't want to say probably, potentially no. It wasn't easily found, but we can search through the data to see if we can find it. Great question. What other questions do y'all have?
Okay, any other questions? All right, well, thank you, Dr. Vox and Dr. Anderson. That was great, doing great work, and we appreciate it. Okay, we're running a little behind here, but it's been great discussion, so I didn't want to stall that. So why don't we take a break till 11:15, and we'll reconvene with the Trauma Administrators Committee report. They're going to be deferred. That's okay, yeah. We'll go into Dr. Dunn's report. Okay, so you're up first, Jim. Thank you. 11:15.
Yeah. Yeah. So anyway,
All right, we'll reconvene and Jim, Dr. Dunn, you're actually up first with your systems report.
All right, well, we've finally started to make some significant strides, as you heard before, with our time to definitive care. But before I get into that, I just want to really thank Marie and Gina for continually having to try to deal with mapping issues between ESO and ImageTrend. That continues to be a problem, but they continue to do well with that. The data from ESO from the trauma centers are now flowing into ImageTrend. There have been some new data fields that we have to try to realign, but that process is moving forward, and the state is able to get the data that they need from a state level, so that's good. The time to definitive care project is still ongoing. We're trying to answer this question from multiple different angles. The current angle that we're working with right now that we've got the most traction on is the individual study between Macon, Georgia and Savannah. As I said before, we've got about 1,800 patients. Data collection will be shut off sometime in late August, early September, and then we're going to start data analysis. So we hope to have information to present to you guys in the November Trauma Commission meeting. And that is, we'll finally have a complete data set of those 1,800 patients. We have, time the ambulance was called, time the injury occurred, time the ambulance was called, time the ambulance got there, time the ambulance left, time they arrived at the first hospital, how long they spent at the first hospital, when the ambulance arrived at the first hospital, when it arrived, when it left, when it arrived at the final hospital. So we really have the data that we need finally. Granted, it's on a small set of patients, only 1,800, but it's a start, and I think we can start working on some action plans once we've analyzed that data. So that's very, very good news. The other angle we were trying to look at was from a claims data set from the University of Georgia. They did a great study on mental health, and we were hopeful that we could use that data set and use the public health group at Athens to help us with the time to definitive care. That's been a little bit challenging. Dr. Benjamin and I met with Dr. Johnny to try to figure out how we can answer those questions. And as it turns out, most of the data that we need that we could get from the claims data set, we've actually can get from the trauma registry. So we're still going to work with Dr. Johnny to see if we can answer some other questions, but I'm less than, it may be that we're not going to get any time to definitive care from that data set. But I think the relationship has been fruitful, especially with the Department of Health at Athens. And so hopefully we'll be able to continue collaborating on future projects with that. And then the GQIP data set and the state data set are the same, but it's slightly different than the NTDB data set, which is the National Trauma Data Set. So I just talked to Gina this afternoon, and by 2025, everybody will be on the same page. Everybody will have the same data that the American College of Surgeons or the TQIP or the NTDB requires. So we'll be able to, we're all collecting the same data, which is incredibly important. NTDB is adding another couple of different fields that we may have to add to the GQIP and the state data set so that everyone remains on the same, with the same data set. But I think we'll all be aligned starting in 2025, assuming nobody changes their requirements. And then I'll be happy to answer any questions, but that is all I have for the Trauma Systems Performance Committee.
Dr. Dunn, that's great that you're gathering data with Dr. Ashley about two trauma centers and finally getting into that ditch to door information that's so critical to improve the trauma care. But what plans do you have for making that more widespread? In other words, to quote the great James Dunn, you may be comparing apples to kumquats if you're assuming that the issues that you face in Savannah or that Dr. Ashley faces in Macon are the same as what Dr. Medeiros faces in Augusta or Atlanta or Gainesville. So do you have plans to somehow expand that once you've gotten a grasp of your data?
Well, I think that the problem with answering the question is acquiring the data. Ideally, everything would be in the trauma registry because the trauma registry requires us to collect all these data points. The problem is getting the trip reports out of GIMSIS for the EMS. That's really been the desert for us, and that's been
from the first hospital to the first hospital. The
Right.
second one we've always found. It's that, quote your statistics, from the first hospital, the first PCR is the one we have trouble getting.
Right.
Or finding in GIMSIS or whatever. And that's, you said what we had, what was the
About
number?
15, at least in my data set, and similar to Dr. Ashley's data set, about 15% that are in the trauma registry for the first trip sheet, and about 80 to 85% on the second trip sheet from hospital 1 to hospital 2. And there's a myriad, reasons for that, whether it's misspellings or wrong or transposed digits or whatever. So I think that the next step in the plan would be to get with the state office and figure out how we can overcome some of those hurdles. And maybe instead of having manual input of data for those trip sheets, is there a way we could scan that data off a driver's license or something so that the data is, we take the human error element out of it, because that's really what's killing us right now. We could not have gotten to where we are, as I stated before, without the state office's help, because using GIMSIS and at least the access that we have, it can take 15 minutes to find one trip sheet. And when you're dealing with 18,000 reports, that's just untenable. But it's been, to get where we are today, right now, it's been with the help of DPH and the state office and manually calling each individual EMS office and saying, hey, listen, I need your tripper sheet for X. And that just is, it takes a lot of man hours to do that, a lot. It took us almost a year and a half for just 1,800 patients.
And I guess that's what I was trying to ask is what insights have you gleaned from your work to share to make this more widespread as far as the difficulties you faced in getting the data, and how could you help the other level ones particularly not have to slog through that the way you did, if there are any streamlined ways to do it back in the
Yeah, I don't know if we've got those answers yet, but I think we need to get with Tracy Johnson, her team, and my team, and then put our heads together and find out if there's any way that we could get the data better, or if there's an easier process to get the data. Right now, we were just so focused on getting the data, we weren't really focused on how to improve this process. But I think that's the next step for sure, in order to make this statewide, because as we all know, the Atlanta community and the rural community are two separate, birds, and it's, apples to kumquats for sure. Thank you. Any other questions?
I'll just make a comment, Jim, to follow up. What we have noticed working the state office, specifically Kelly Joyner and her team and all the folks there in the, I don't give you names out, but all the folks involved, they sort of took this as a PI project to figure out why these first PCRs weren't in the system, or if they were, why they couldn't be found, or what was the issue. And so they actually, and I haven't seen their sort of drill down analysis. I know they looked at it, but they actually took this on as like let us take the lead on this. We want to figure out why, was it fat thumbs, just a name, the name spelled wrong, or maybe the wrong date, just, in the heat of battle, anything can happen. And so they found out some interesting things that they're pulsing back to the EMS agencies, like, hey, so from what I'm being told, that they found some PI issues that can improve the input in the system to make your job, if you try to do this now, easier. And what they did notice too is when they switched from, as the timeline went on, they noticed, because they looked at a lot of these going in NIMSIS or GIMSIS or whatever we're calling it now, but when they went into it, they were seeing improvement over time of the agencies able to get their data in there correctly. So that's a positive. So I'm hoping, and now they're taking this back. So a lot of, even though we're really interested in just the data, the state office was interested in making the data better, and they use this as a sounding board. So hopefully that's going to help you as you try to do this. And certainly now we have a template that we're more than happy to share with you, Regina, and Wellstar or whoever, we've got the data point. We think, we probably might have missed one, but we think we have a very good template that the whole state, every region can use. And now we know we have 2 out of 10 regions. We have his region, my region. So we at least have some data from 2 regions. And if you all jump on it, that'd be 3. If Wellstar Place spreads out over more regions. So anyway, we're building momentum. So we just have to stay the course. But I think we at least got a tool now you can use. The state office has at least made some improvement on data capture and at least sort of knows what to look for and is pulsing out some education, like watch for this. So I think we're making progress. It's been an arduous task.
One of the lessons learned, I think, that I just brought to mind was the initial data set that we drew from was all transfers, right? Because that's what we're looking for, right? But what we failed to realize is some of those patients, it turns out to be a significant number, actually went to the first hospital POV. And there was really no way to identify that because we saw, well, we only have 50% of our PCRs or 15% of our PCRs. Well, some of that was because there was never a PCR because they went to POV. And so trying to tease that out has been a challenge as well. That concludes my report.
All right, great work. Thank you, Jim. All right, we'll move into the Trauma Medical Directors Committee. Dr. Vassie, who I believe has been very busy following the email chains. So go ahead.
There we go. I'll just say, I'll be interested in seeing that template as well. But we're in the process of trying to build our research bandwidth at Northeast Georgia through a lot of clinical growth. So I'd love to see what we'd be up against in terms of being able to contribute to some of that data. So I'll try to be as brief as possible. I will say that the TMD committee had our first in-person meeting in, I don't even know how long, a long time, in March. Unfortunately, due to family emergency, I had to step away at the last minute. So a lot of the things that we had on the agenda to discuss and work through were tabled, as you'll see on the report. But thanks to Dr. Dunn, Dr. Ashley, and Gabby for stepping in at the last minute. We were able to get a couple of things accomplished. One of the things is established in a smaller work group for the redistribution of the early transfer guidelines and revision and redistribution of those. So we've got that in the works. Hopefully we'll be able to get that across the finish line pretty soon. We were also able to decide on some recommendations for approved items for purchase for EMS services with some of the commission funding. And the only thing I would add to that, looking through the minutes, is to make sure that pre-hospital blood, anything having to do with pre-hospital blood administration be included on that list as well. I know in our region, that's been the barrier to expansion. Our hospital has agreed to continue to support the blood product cost for providing that, but we're certainly asking our EMS agencies to shoulder the cost of the equipment to make sure that that happens in a safe way. So that'd be the only thing I'd add to that. The other item that Dr. Ashley was kind of referring to is I figured out a way to get a lot of response back from the committee members, and that's just mention something controversial and try to come up with a group opinion about it. So we were asked to kind of consider a proposal that was brought forth, at least maybe not formally, but at least informally at the last MSDAC meeting, about a position statement on where needle decompression for traumatic pneumothorax or tension pneumothorax is best done. And the proposal seemed to indicate that there's a lot of support from our pre-hospital providers from some direction, at least, for ICE, kind of abandoning the lateral approach, which is actually the recommended approach nowadays based on the data. So we got our heads together and we're on the verge of, after clearing up some miscommunication, after talking with you guys and Dr. Benjamin at the break, on the verge of being able to submit a letter that at least does our best attempt at collating a position statement from the TMD committee that we'll kind of ask for your guys' input on before we forward it on to the right people at MSDAC. But that being said, our next meeting will be virtual, associated with the GQuip meeting next week. And I think that concludes your report.
Okay, any questions for Dr. Bassi? Terry?
Yes, sir. So what, do you have any insights yet as to what y'all's position will be on
Well, we're going to be certainly supportive of the lateral approach. The only, and Dr. Todd and I were just talking about this, the only question I have in interpreting the data, the preponderance of it shows that's the shortest approach to the pleural space, both from cadaver studies and CTE studies. There's maybe one recent ultrasound study that presents them as equivalent, but with some limitations. But for sure, the preponderance of the data support ATLS and PHCLS recommendations of lateral approach. So we're going to pretty strongly recommend that we stick with that as our first choice. Now, I wouldn't say that that means that we can't use the anterior approach. That should be still in our toolbox, but the recommendations are based pretty soundly in data, and unless and until we see data that disagrees with that, whether that's complication related or whether it's success related. Unfortunately, or fortunately, I guess there's not really any new way to look at that. And that's why some of the best data is still, maybe 10 or 12 years old, but it's still really good data and hadn't been refuted. So that's the gist of it. We're just working on the final wording to make sure everybody's happy with it.
Dr. Vassie, are the recommendations going to be location-based or location and catheter length?
The recommendations are basically in response to the proposal that we saw, are basically just location-based. We all have, all of our different services have different indications, and we'd love to have a proposal put forth in that community to solidify our indications. Because I think if you look at all the needle decompressions that are done in the field, some of them were for maybe not the most definitive indications. But certainly catheter length it varies. I mean, if you read TCCC, that they say the longer the better, but we all know that there's some important things in the chest, especially if you're on the left side, that longer may not be better. So I don't know if we're going to get into the catheter length discussion just yet.
Any other questions for Dr. Vassie?
And the only other thing I would add to, if Lynn's still on, be happy to jump back into the discussion about the transfer recommendations and the template that they're working on. I'll be happy to offer any help with that.
It sounds like that would tie into what we talked about at the last meeting. The transfer letter, transfer poster, or things to think about transfer feedback. It sounds like you're probably just working on in general transfer in adults, and they're working on peds. So it might be nice to marry those two together, or at least talk. So I think that's a good idea.
Yep, absolutely.
I think your project on when to transfer out and reworking that, sending a letter from the TMD committee, I think that's great. So please proceed with that. It's great work.
And I think you identified a great communication tool, the trauma medical director email group. You got a lot of responses and a lot of chatter on that group regarding the location of thoracentesis. So I think we got a good plan moving forward about how to get information out and how to get feedback back.
Absolutely.
And I'll just throw a general question out to the room based on my ignorance. So anybody answer that knows the answer, but like the hymns, I think this has been a great, as I've watched the email chain fly around back and forth, a lot of enthusiasm. I think the TMD, the Trauma Medical Directors Committee, and MSAC should have some interaction together because they sometimes work on the same thing. Like this was a great project for both. So is there some way, I don't know who's in charge of MSAC or, you know, I don't live in that world, but it sounds like that there ought to be at least a liaison either way between the two committees so that they could talk and is there a way to do that? Or
Yeah.
who's in charge?
Theoretically, yes, there's an open position currently for a representative. I don't know what the specifics about what the MSDAC folks are looking for, but there's an open position for a surgeon, trauma surgeon member. That's I think Dr. Register had previously occupied for a period of time.
I think
But,
Michael can probably comment on that. That falls under purview of OEMS&T. I don't know that it was specifically a trauma surgeon. I know she was on briefly and then, but you might be able to help us figure out.
Yeah, I think that was what instituted this conversation.
Yeah, I just happened to be on the call and saw it and didn't, figured it would be just. Yeah. Is it specific for a trauma surgeon or was it a regional based position? Do you know that? Okay, I think what we're just trying to figure out is how do we make sure when those, like if I hadn't been on the call, I would not have known to forward that to Dr. Vassie. And I think those are things that, with all the expertise we have in the state, it would benefit us to have a mechanism to be able to put stuff like that through that group for vetting before it goes live. And thankfully, they didn't approve that on that call. So we had some time for you to get feedback. Okay.
Oh, he's on the call now? I don't know how to do that. Do you know how, Gabby? Can he talk?
Hey, can you hear me now?
Go ahead.
Thanks, I appreciate it. Yeah, in regards to what this discussion, so Dr. Register, of course, is a trauma commission board member, and she was previously our trauma representative on MSDAC, and then unfortunately has had to vacate the position. So it was open. We have since filled that position. In terms of the membership, we're generally always looking for other that are interested to fill these positions. So we'd be happy to take a letter of interest and a CV for anyone who is interested in a position. In terms of the position statement that MSDAC has drafted, it was drafted and it came through from the MSDAC subcommittee of the scope of practice. And that group, there's around 6 of them that are pretty active in that scope of practice subcommittee that moved this position statement forward, and it's in that subcommittee. It was brought forward at the last MSDAC meeting for a vote in the middle of summer. That meeting was very poorly attended, so due to the low attendance, they decided to not vote on that and to defer it to the next meeting, which I can look on my calendar right quick. It's coming up, I believe it's in October, right around the same time as the GEMSA conference is. So I believe it is the 15th of October, and then it will be on the agenda for then. And yes, it is October the 15th at 10 a.m. Were there any other specific questions that I can answer about that?
Dr. Harvey. So I guess, Dr. Bassett, you have a comment on what you would like or what you have a recommendation or with the meeting coming up or? would you
Yeah,
like to
so-
present something or send something to that meeting for consideration, or
Yeah,
like, what should, I guess my question is an open-ended question. Where do we go from here? Everybody's on the phone and talking now, thanks to Michael. Thank you, Michael. So, this is a good time to say what we think we need to do or make.
Yeah, it's very helpful. I think, I guess, a statement and a question for Dr. Rhodes. One, in reading through the proposal, it mentioned recent data indicating increased complications. If there's published data on that, I'd want to see it. And I guess the other comment I would make is, as I mentioned before, I think our medical director's opinion and position on this is that the lateral is going to be our preferred based on the data that we have. And I would also just offer, resources in terms of either a continued conversation or further education for you guys to let us know what your struggles are, and for us to maybe add, provide any additional help that we can from a trauma center and trauma surgeon standpoint to overcome those difficulties. If there is truly a concern that's welling up from the grassroots about the lateral approach, we definitely want to know about it. If it's something we need to publish and get it out there, then we can certainly help do that as well. But the letter that'll come out of our committee will definitely support the lateral approach, and it should be available. And I don't know how best to get it in the right hands before the October meeting, but we'll certainly do what we need to do that.
Thank you, Dr. Vassy. So to be super clear, I'm not entirely certain what literature, if any, they're referencing when they say recent data. What I will say is that this was spearheaded by Dr. Nix, and in his personal practice has found several liver lacerations very recently that are coming in essentially from the spear being placed in the lateral chest wall. Whether it is poor performance on the part of the paramedic placing it, or, I don't know what all goes into it. I just know that there's been enough that it raised concerns. He brought it forward to IMSDAC. That group had some anecdotal experience, I guess you could say, with the same concerns. And so that's where it was born at. I think what I would like to do is to put you in contact with Dr. Nix and let the both of you kind of discuss this and talk about it and see where that conversation leads. And I'm certain that they would be happy to entertain, some input from you and the committee at large, as well as, probably consider a letter or whatever in terms of their next meeting. So if it's okay with you, I'll put you two in touch and let y'all have a conversation and see where that leads.
Yeah, that'd be great. Thank you.
Yes, sir. Thank you.
Dr. Todd?
Yeah, the only thing I was gonna say, I appreciate we all have experiential learning that we do, but we should probably just rely on the best data in the literature and not let our, certain untoward outcomes change our entire practice when the literature supports the lateral approach.
Okay, well, this has been a great discussion. I'm so glad, I'm sorry, who was on the phone? Dr. Richard Rhodes? And thank you, Richard, for being on the phone. This is a really big help. And then Dr. Vassy for, sort of spearheading the TMD group. But I think that would be great if you all could talk, Dr. Vassy, and I think we can work this thing out for the best route to go. So thank you.
Absolutely. Thank you.
Okay. What's that? Very good. Okay, we'll move now move into the the Georgia Trauma Foundation. Dr. Bleacher.
Thank you. To start my report, the foundation board and executive director held their annual meeting in June, at which time we engaged a consultant who who's expert in nonprofit leadership and developing strategic plans. So at that meeting, we did revise our mission, vision, and value statements, and also created a new strategic plan that's now streamlined, concise, and actionable. And we are starting already to work on leading that strategic plan. Next, under fundraising, friend-raising, in the past fiscal year, we raised a little over $110,000 between Georgia Gives and the major fundraiser at the Porsche Experience Center. And we're going to now start working on awarding that money in the form of grants so that that money gets put to good use. And so the foundation is pleased to announce that we are going to be awarding grants, and a lot of the details will be coming out shortly, but the idea is that we will offer 8 grants, maximum $10,000 award for each. The application period will be September 1st to October 31st. Details about the application will be on the website by the end of this month. And we don't want to keyhole these awards in any one category. So any trauma stakeholder that has a mission-aligned project that they want to get funding for, they can apply, and we will consider education, injury prevention, public awareness, advocacy, the whole gamut. And we will hope to have the applications reviewed and ranked so that awards can be given roughly the beginning of the next calendar year, so January 1st. Again, all of the details are still in progress, but this is a huge step forward for us, and we're really looking forward to being able to do that. One other thing about those awards, we talked about perhaps offering them as a matching award. So if an organization has a grant from another foundation or another organization and like matching funds, we would also consider that. Next, on rural continuing education, we've added a couple more courses. So the number of courses that are going to be offered this coming year are 20 with 250 learners and 2,690 hours of classroom hours. And finally, board expansion. We now have, and it's in your packet, we now have board members from 8 of the 10 regions in the state. The ones that are not represented currently are regions 4 and 8. And we will be taking that under consideration as we continue to expand the board to hopefully get representation, and particularly in those that don't, in those regions that don't currently have representation. That concludes my report.
Thank you, Dr. Bleacher. Nice report and very, very encouraging for the progress in the foundation, for sure. Several questions, mostly just informational issues. Is the goal for the board to have a board member from each region? Is that the plan? Or is there, what's the plan for the board makeup, I guess?
Right. So that is not necessarily a be-all, end-all criteria. What we want is to strive for representation across the entire state, but we take that into consideration in addition to what talents or skills does a potential board member bring to the table. So it's not just a matter of geographics, but that is one of the criteria that we use in expanding the board.
And then another question would be, the $110,000 that was raised last year, was that all net profit or was that just revenue and then expenses had to be taken off that for like the Georgia?
Net profit.
Net profit, excellent, excellent. And then the final question would be, what do you need from us, from the Georgia Trauma Commission? I know we've had several meetings with the foundation board, with Dr. Saunders, and she brought up a point where it would be helpful for us to set a goal to come to the commission, the foundation, say, hey, listen, we need $100,000 for X. And then you guys bring that back to the board. And then you say, can we do this or not? And if so, it takes us 2 years to do that. Is that still in the strategic plan, or do you need that from us? Because we can come up with 10,000 ideas.
Right. Thank you for bringing that up, Dr. Dunn, because of the relationship between the commission and the foundation, we want to make sure that we are aligned with what the commission wants to accomplish. While the foundation is a separate entity with its own governance and all that, we would appreciate some guidance as to projects that you recognize would be helpful for the commission to have funded, and that the foundation may be a good vehicle for funding that project. So we don't want to necessarily only rely on the commission to identify projects, but certainly if the commission has a project that is of special importance that we can help, that would be great, because essentially, you know, we have very talented board members who are actually excited about raising a lot of money. And yet when they go out to try to raise that money, potential donors want to know, what's this money going to be used for? And if you have a project in mind, and particularly these big ticket things that may take a couple of years to raise, like a capital campaign for a school or a hospital, whatever, that we can start working on that with a goal in mind. And so I thank you for bringing that up. That's exactly what we would like to see as far as some collaboration.
Okay, then maybe we need, as a commission, need to put our heads together and think about, you know, what pie in the sky thing that we would like to fund, that we don't want to use the state funds for. I don't know what the governance or their legalities surrounding that are, but I certainly don't want to affect your donors. Because I know sometimes there's you want to be, a foundation wants to be separate, and the donors want to know that that money is not going to be used for educational, for administrative expenses, and that they don't want to have their hands tied with how that money can be used. So there's a lot of issues between the two. I just, that helps, that you're interested in that, and then we can move forward with that.
One other thing that I'd like to bring up, based on the discussion earlier in the meeting, just as the commission is considered a funding source of last resort with the trauma centers and such, we would like to provide access to funds to organizations that don't have any other avenues for them. So, you know, for example, earlier in the meeting, we were talking about injury prevention. We would love to fund injury prevention, but if there are mechanisms or discretionary funds to fund injury prevention, we'd prefer it come from that first and maybe be matched by the foundation to actually multiply that award.
Thank you.
Thank you.
I'll say the same thing. I think, Jim, to your point, though, I mean, I think to what you were saying is, if we as a commission came and said, this is something definitively we want to raise this fund, we're going to bodies to raise funds. So even if we want to do injury prevention and have a robust program statewide that does blah, 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 that's going to be a lot easier to campaign why they need to give money to the foundation to support this. I think the challenge you guys have right now is there's not a true distinct ask. That's tough.
So thanks, Jim, for bringing that up, and Rob, and we're really finally getting to a point. The infrastructure, we're starting to make progress. The infrastructure is being built. I think we actually, as a commission and a foundation, understand our lanes. And so, and thanks, please take that back to Dr. Saunders. She was instrumental on a phone call helping me understand that. just a one-on-one call. So her knowledge base for the foundation has been tremendous. So please relay our thanks to her.
Yeah, we have a
personally.
very talented group of people.
And not just single her out, the whole board, but I mean, just, she's the one that taught me the different lanes. And so what I would like to recommend is that I think we're to the point of doing what you just said, Jim and Rob. So I would like the budget, so to give you what you need, I would like, and I think you're ready for it now. I'd like the budget committee to take this on. I'm not sure. I think this is a place, so this is an open discussion. If it's not the place, whichever committee, but I think our budget committee, which really has EMS representation, it has trauma center representation. I'd like Crystal also to be on for this specific topic, because you have access to all the RTACs and you know what's out there. For us to, by the next commission meeting, not this just 10 years down the road, but I like this to be tight and get it done, because you need to know. By the next commission meeting, for us to come up with 5 potential projects, and we can divide them in 1 or 2 long-term, like 3 to 5 years, and some, like Memphis says, Dr. Saunders, short-term wins, like 1-year projects that are shorter, easier. So light lifting, heavy lifting. And then bring that back. They're potentials. It's not like we're going to do this. It's like, then bring it back to the commission for all the commission members to weigh in and discuss. And obviously you are a commission member and you're on the president of the board of Georgia Trauma Foundation. And then once the commission says, we like number 1 and number 4, the other 2, or we can't do. Then we can pivot and say, you can take back, the commission has number 1 and 3, these 2 proposals they want. Does the board think that we can do this, or that we can't? And then you bring that back to us at a time. And that would give you what you need. Does that sound fair?
Very fair.
Okay.
That's exactly.
I think it's time for us to ante up and do our job, and we understand our role now. And I think we built the infrastructure to take on that role.
Great. It's exciting stuff.
Well, thank you, John. I'd just like to publicly acknowledge you. It's been some tough times. You've led through some difficulty, and you hung in there even when your buddies were punching you in the nose. And we love you and we appreciate you. So
The 1-day board meeting was amazing to be part of that and see, like, the ideas come out, and there were just so many more voices around the table and just expanding the board. Yeah, and great ideas.
And the level of engagement was really encouraging.
John was on my team, so I was lucky. He had all the creative juices flowing.
The legacy of his, he wrote the initial list. And he did the commission, so having his historical perspective. He exposed him and then see his passion. Project on, where it is now, it's also almost as more excited about where it's been.
no, it's getting exciting now. So I'm glad you hung in there. Okay, we'll move into the Georgia Quality Improvement Program. Who's going to jump in? Gina?
All right. I'll try to be quick. Our work groups, VTE, had their first meeting. They actually meet again tomorrow, and we had a really good meeting. They're working on, their goal really is to come up with a VTE prophylaxis guideline, kind of like we did with VAP, and the multimodal that can be pushed out to centers and they can adopt as their own. So we're working on best practice. Luke is also analyzing some data that we have, because we do have the VTE data, raw data in the central repository, because all the TQIP centers collect that process measure. We also will have that as the next analytic in Arbormetrics from that. And then the time to care work group, we've got 2 leaders now, and we're working to set up that meeting in the next couple of weeks for that. The first quarter of 2024 data has actually been loaded and is visible in Arbormetrics. So, and it'll soon be time to load the second. The centers will be submitting their second quarter of 2024 here in the next couple of weeks for that. We're building some additional filters in Arbormetrics as well. Still encouraging centers to use it and provide feedback, and we'll be presenting some more data at the fall meeting with that. So I have some really good news. So actually last week, we got our official letter. GQIP is now an official patient safety organization. So we have that designation now officially. So we're one of the 110 that are listed by AHRQ. 70 are listed that serve Georgia, and actually only 3, including us, have their home state listed as Georgia. But all of the PSOs can operate nationally regardless of their home state. But that was a very exciting letter to receive back. And a lot of work. We still have a lot of work. They give you a year or so to work on some other things. So, but it was nice to get that letter, and we can put that little seal on the GQIP PSO website for that. Yeah, it's kind of, well, maybe it is kind of like a provisional, but so we have our virtual call next week with the TMD call. And we will have a fall meeting in conjunction with the commission meeting in Cordele. It will look a little bit different. So we're kind of morphing what the meetings will look like. It'll be a little bit smaller. It will just be the TMDs and TPMs. The whole session will probably be much like a closed session because we'll really be able to dig into the data, maybe do some case reviews, those kind of things. And then we have a tentative date location for the winter meeting in February, hopefully at Callaway Gardens is what we're looking at. So happy to entertain any questions. Or if Dr. Todd has any additions to that.
Anything from us, Gina?
I do not think so.
I do have a question, two questions. Thank you. That was a good report. Thank you for the data. I have been using the data. I've been in there asking her a million questions, and she keeps reminding me that there is a data dictionary.
But I do answer your question.
But she does answer my question and tell me what page I can find it on the page. And I have already looked at the first quarter of 2024 data. It's a public service announcement for GQIP. I do encourage everybody to log in and use the data. I went in there and looked at the data. It's a great way to check validity of your data before you send it onward. But I noticed that our CAUTI rate had gone up in the first quarter and had been very, very low. We had 0 CAUTIs for several months, and all of a sudden we had a jump. And so immediately I was down in the ICU with our clinical outcomes manager, and I said, "Is this true? Is our CAUTI rate up? But we captured this correctly?" And sure enough, 3 out of the 4 months that were contained within there, that we had a CAUTI, so the number had gone up, and they're already on it, looking at what they can do to reduce that rate. Again, we had done a knees to navel cleansing program and looking to see, are we still doing that, or is that slacking off, and is that what caused our blip in our CAUTI rate? So it's very useful data. Once you put it in, it doesn't take them very long to spit it back out at you. And then we're also asking a lot of questions about how does this map, is this correct? 100% of our pre-hospital data was missing. And I said, how can 100% of our data be missing? To Gina, and she drilled down and looked at that, and it was the same thing you're finding. It was actually pre-hospital 1 for transfers. That data was missing on those patients because we just have a hard time finding it. So we don't, it's a balanced quality and efficiency, so they don't spend a lot of time hunting for it. But it's important because it's missing. And if we're really trying to look at that longitudinal data, we can't get it because we don't have it. So I do encourage people to use it. 2 questions, I guess, for Dr. Todd. I did notice that the data currently is not risk adjusted. And one of the things that we were going to, or that we keep talking about, was how important it is and how special it is to have risk adjusted data. So right now it's just kind of data in, data out, like NTDB. which makes it a little skewed if you're looking at smaller volumes of things. And then the other thing is there's a good number of filters, unplanned return to the ICU, VAP, CODIs, like I mentioned. I can't remember the other ones. You might know what they are with the group, but what is the plan for risk adjusting, and two, kind of what is the trajectory or vision for adding process of care measures or additional filters?
Yeah, I think on the risk adjusting, we just reached out to Michigan, to the MQuip collaborative. They're the ones who really kind of masterminded this and kind of did the risk adjusting behind the scenes. So we're going to have a call. I don't think we've heard back from them yet, but we'll follow up with them. Just send an email last week saying, how did they do that? What does that look like? And then figure out how we do that. And then as far as the filters, those actually came from Arbormetrics as far as what they would do initially building out, if I'm correct. And then we can add more of what we want to add into that. Gina, you can clarify, make sure I'm not misspeaking to a certain extent.
Yeah, we actually built our initial data dictionary. So that was one of the things that they started, was like, what were your, 14 things that we started out with, and that started with our initial Mentimeter. So, and it's kind of like they add one thing at a time. So our next will be the VTE process measure, and I've kind of written a draft of that. It's gone to the VTE committee to kind of look at, and Dr. Todd for some feedback, and I really took Michigan's. It's kind of nice. Michigan is great about sharing. They share everything. They shared their risk adjusted model with us, and basically said Dr. Himmler wrote their first model themselves. And Arbormetrics is willing to help, with that. But, it's just kind of like what direction do we want to go with that? That's what they're waiting for with that. And that's, that's kind of a heavy lift from that standpoint. So the direction is kind of like, what's our priority next on that list that we provided next. So some of the filters, we're going to change some of the filters as far as ISS scores, because they broke them down into all 4, but we really want to add, they're going to add that less than 15 and greater than 16. That will probably come in September. That'll be the next one that they add, because we like to filter that way. We don't want to, we want to be able to slice those 2 buckets and not, one bucket, less than 8, less than 9 to 15. We want to have those 2 big buckets. So that will be the next process that they filter that they add. And if there's filters that, or ideas that people had, I can throw them their way at any time. So, I encourage when folks use them and say, hey, I would really like to be able to filter by things that are not already built. Like right now that you can filter by injury, county of injury by region is already built in there, and some other things. So we can add filters, so as centers play with it and learn how to use it and find things that will be useful, that feedback I can take back to Arbormetrics.
And Regina, I think on the risk adjustment, I think when we talk to Mark, it'd be interesting to see how they did that. Candidly, we may not have the expertise in myself to do that. So we may have to look to see, who do we reach out to?
I was just going to ask that.
Yeah. It may be an expense to have someone figure out how to do that risk adjustment modeling for us. I don't know if Luke may have bandwidth or the knowledge, which I really see. So until we really get that from him, I think that's one good learning expedition.
Yeah, I was just going to ask that. Is there anything that you need that we can assist with, or an additional group aside from that? You guys, initial meeting obviously with Dr. Himmler, but expanding that group for some other people that kind of are data geeks like that, because that is a nuance modeling. That's why it's held so close to the vest, if people don't share their modeling.
And it may
be an AI for that.
Luke is working on a project on the NSQIP side with some VA folks. And I know I'm going to butcher his name, Dr. Masterway, with the VA. They've done a project called the QSLIM project, and Luke's working to kind of replicate that with some of the NSQIP data, and they've built a risk adjusted model. So I'm hoping as Luke gets into that and works with those guys that we may be able to, to tag on to some of that expertise, because there is a gentleman that he's working with that project, that has some expertise, so that we may be able to tap into that as he learns a little bit more.
I know you'll probably tell me what page of the dictionary this is on, but can you filter by blunt and penetrating?
I'll have to. Quite possibly, yes.
She'll have the answer for you in 5 minutes.
Yes, give me a minute. I'll look at it.
So I guess from when you say Michigan sharing their risk adjusted, so if that's, again, I don't know the answer to this, but so I'll just throw it out, maybe a silly question, but I assume that, like you line up the 80-year-old diabetic, CHF, blah, 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 whatever risk, whatever little variables you put in there, and then you match it over here to others, and that's what I think of risk adjusted. So if they've already got software, or they've got it, why don't we just take their software and plug it into our computer? So I don't understand all the discussion about, well, we'll find this. If they got it, just plug it in. Now,
And that's what
this,
we're trying-
this
that's
is
what
a
we're trying to
non-tech guy saying that.
And that's what we're trying to find out from Mark. Exactly.
Okay. So I would just I see you all coming now. We've got momentum. We've got some data. We've got some stuff. Let's just do it. I mean, I guess what I'm looking at, you all come to us and say, I need $100 to put this software in this computer. I mean, I need facts. I'm ready to go. I mean, the car's here. I'm ready to get in and drive the Porsche real fast. So tell us what you need. Okay, but who's going to take the lead on that? It's a charge. Like, what are we going to do? Is that, who's?
Yeah, and that's how Arbormetrics, again, they're great at, Michigan explained it, is it's kind of like, and Arbormetrics says, you can take all of these. They said, here, these are all the things that we can risk adjust. We just have to give them that initial direction. And that's where Dr. Himla did the first go round, is gave them the initial direction on, these are the things that I want to use in our initial risk adjustment. And then after the fact, then Arbormetrics has done all the other years, they just review it. So it's this initial out of the gate things, and we may be overthinking it, and that may be where the conversations with Dr. Himla himself come in handy.
So my recommendation, I'll just throw this out if you need a vote. I'm ready to do it. Let's do it. So my recommendation, when you use the word Himla, if Dr. Himla says, this is what I did, just do it. I mean, he's the national expert. So whatever software he said you could have, tell Arbormetrics to do it. So I'm going to make a motion as the chair right now today, whatever time it is. Whatever time, I'm making a motion that we take the Michigan risk adjusted model and we implement it within 30 days in our system. That is the motion. Can I get a second?
I'll second it, but I want to move right into the discussion if we can from that. So my question is.
All right, I'll take off the third. I'll make a motion that we take the Himla, Michigan software risk adjusted model and use that in our database. That is my motion. Can I get a second? Second. So it's open for discussion. Now y'all can slice and dice my enthusiasm.
So just to clarify, Gina, is the Himmler risk-adjusted model, what I heard you say is he talked about the elements of the model and make sure that we have those elements in our data set, but he didn't give you the formula, or did he? Give you the formula?
Well, kind of, sort of, yes. It's a very, they gave us the spreadsheet, but I'm not a data scientist. So
why not?
Why not? It's just not my wheelhouse. So yes. So I'm not really sure, how to marry those things. So.
Well, I'm not asking you to do it.
Yes.
That's not my motion. That is not my motion. I'm just saying, I can make a second motion if we get through this one. But what I'm saying is the concept of we know what we need. We know what works in Michigan. That's who we look to. Let's use that. We don't need to invent our own data risk adjusted thing. Just use their thing. Then we figure out how to, I don't expect you to know how to do it, Rob. I certainly don't know how to do it, but we know people that can do it and we can pay them to do it. Let's get it done. That's what I'm saying.
Yeah, and that's what that call is going to help us figure out what that looks like and then what is the ask.
I just want us to say, we are going to adopt this model And then you guys come back and say, we can do it in X amount of time with X amount of dollars. And we need John Smith or Sally Smith in California to do it. That's fine. That's my motion. So.
Gina, you and I talked about this before. Does the fact that Michigan uses slightly different definitions going to impact that, our ability to replicate it? Because we stuck with the TQIP model.
It could, because their data is a little bit different. And like I said, it could be, you know, that we're making this more complicated than it needs to be, you know, the conversations with the folks at Arbormetrics, you know, that I've had, and we have Michigan's, you know, files, which I have given to Luke, you know, to kind of review, along with what Arbormetrics has said they will do. I mean, we could go to Arbormetrics and say, hey, we want to use these items to risk adjust, because we have a list of things they can use these. Y'all just build it. They will do that. You know, based on what you've utilized for Michigan. They would do that for us, and without our input, you know, is that the right way to go? I don't have the answer to
I
that.
think what you're gonna risk adjust based off of price shouldn't vary based on our definitions. And that's why, getting to your point, I think it'd be nice to know what they use for their risk adjustment and replicate that. So they've been doing that and it's been effective. And so thinking about what we risk adjust for probably won't vary based on definition. It may be slightly different, but still based off our definition, which we're gonna risk adjust for, I don't know, X, Y, Z. Probably not our definition, this is something for us, that's our risk.
Is it the definition of the data entry side, or the definition on once it comes over to Arbormetrics, like what you picked? Does that make sense, that question? Like, because I would imagine Michigan centers are still using the same TQIP definitions for complications.
They have added some fields. That's the thing about
So they may have
Michigan.
fields that we don't have. but
Yes.
Risk adjust all the other fields that they do have that we have. and
Yeah.
then the ones all that they add to those fields.
And maybe I know Michigan has their own statisticians, and maybe those folks might be for hire too, you know?
100%.
You know, we pay one of the Michigan people to talk to Arbormetrics, and you all stay out of the way, because, you know, unless you're smarter than I am on this, because I don't know anything, and just let them do it.
But
And if they can only do 80% that line up, well, then the enemy of good is perfect.
Yeah.
So just
But
do what you
from
can.
my understanding from Jill, like you know, after Dr. Himla did the first looking at the data, then Arbormetrics does the rest. There's not, their statisticians are not involved.
This is a geek thing. This is like the guys,
Yeah.
you know, they talk, you just tell them, we want you to risk adjust on these variables, and they know how to do it. They'll figure it out.
So, and I have the list from Arbormetrics, their data scientist, of what, you know, they can use to risk adjust. So, and then I have the list from Michigan. It's just,
I am also not a data scientist, but I would imagine that the risk adjustment model isn't just, everything is, all the items in the risk adjustment model aren't equally weighted.
Right.
So they have to
Exactly.
be separately weighted, like COPD may be 3 times as important as asthma or something,
Right.
you know, I don't know, but so I think that's the key.
Yes.
So you need the
That's all you
formula.
need.
And that
you
may
need
be,
data and you need
and what's weighted in Michigan might be different, like hypertension may need to be weighted more here than it is in Michigan.
No,
I
it
don't
does not. No, no, it does not. We got to stop that kind of.
Yeah, so.
We're too far down it. No, it does not. Hypertension is hypertension in Michigan and Alaska. It don't matter. If it's a 3 in Michigan, it's a 3 here. So just use the Michigan. If I know the values, like hypertension is a 3 and COPD is a 1, just plug it into the computer. That's all you need. That's all I'm asking for. Just plug it in. I mean, once 10 years down the road, if we want to challenge Michigan and say, I think hypertension should be a 2.5, let's go take on Himla and the Michigan folks and say, I think it should be a 2.5, but we're not there yet. And we don't need to be there yet. We just need to know, we need a grid, and that's all we need. We just need to know their numbers and let Arbormetric put it in. Does that make sense? I don't want us to get too far down in the weeds. We got to crawl before we can walk.
Thank you.
All right, wait a minute, we still got a motion on the floor, so I got. Huh? Motion and a second. And a fine discussion, an enthusiastic discussion. So, any other comments on that? So we get the votes. Let's see if I get voted down. It's okay to vote no. I don't hold any grudges, but I don't usually make motions, but everybody vote what you think. I don't want to leave some objection, but I am ready to move on this, you know. But committee appointments are coming up. That's true. Okay, any other discussion? All right, I guess I'll take, all those in favor, aye.
Aye.
Any opposed? Okay. All right, you are empowered now to go forth and be great, and conquer. And if you make a mistake, it's on the commission. It's not on you. So be bold and be powerful and empowered. Go forth and conquer.
There you go.
Okay, any? No, I won't. I know some Georgia Tech students that'll do it for nothing, you know. My son's a biomedical engineer. I'll stick him on it. He may charge a little bit. I have to get some of the students. He graduated. So. Family and friends discount like Verizon, right? Okay. Where are we here? Up to John. No, it's OMS&T, Stacy Smith.
Good afternoon. We're moving into the afternoon, so I'll try to make this quick for us. So some successes for us with the Office of EMS and our program. We've been working hard with the level 4s to get them back on track and get them redesignated. I know COVID messes up everything. So we're happy to say we're getting them on track this year. We've done 4 consults so far, and we have 2 more scheduled. The consults that we do just helps reestablish our connection, reestablish their goals, reestablish their guidelines to make sure they're on track to be designated, because we want them to be successful and not fail. So we have completed 4 designations or 4 consults, 2 designations, one of them recently being Effingham. So congratulations to Effingham. And then we're going to have hopefully 3 more designations by the end of the year. So that's good for our level 4s to move forward. Another success for our office with consults is Marie Probst, our registrar, state registrar, and Gina have been working with all the facilities for QA data sessions. They have completed 12 sessions, and they are continuing to schedule them on a monthly basis. So that helps them make sure their data is being put in correctly with their QA sessions. And that way the centers know how to do their data, to download it successfully to our office, to GQuip, to the national database, and to TQuip. So these have been some great sessions that they've been doing to see if any data's fallen through the cracks. They make sure they can pick that back up. If you're interested in those QA sessions, you can reach out to Marie and Gina. They can get it scheduled, but they do have a monthly rotation that they're working on. Moving into with the data, our image trend registry from 2021 to 2024 has been uploaded to Biospatial. Biospatial will continue to work on the data to finish calendar year 2024. We also have the 2023 image trend report for the registry was exported by Dr. Liu. Dr. Liu has confirmed that the 2023 annual report will be published in August. And any of our annual reports are on our website, and that link is in the notes. So you can check our website for those reports. Moving forward with data looking into 2025 year, the data dictionary for 2025 and schema is in preparation, pending the ACS National Trauma Database Data Dictionary. We will include those additional fields from the 2025 schema. The 2025 Georgia Trauma Registry criteria, it will be aligned to the 2025 National Trauma Data criteria. The Georgia Trauma System and Data Quality evaluations have reached a mature level, which requires us to ensure our state data can be equally compared with the national data. So the registrar subcommittee and the trauma system performance committees agree with that alignment. We are also working with the 2025 annual registry maintenance for the EMS providers into the new ESO registry. I commend Marie and all her work to uploading all the IDs and facilities and EMS agencies into this new registry. It's been a task. So they're going to adopt the national provider numbers for both sets of providers to align instead of just the Georgia homegrown numbers. And Grady Memorial is the test center for this new ESO platform. And then other things in our office that's going on. The Office of EMS is working with the EMS committee to verify vehicle counts for upcoming equipment grants. They're also working with Liz and Courtney with the trauma system project to identify trauma hospitals and EMS locations for air and ground across the state. And then for education, and that has been a big topic today, the Office of EMS has worked with the commission and RTACs to choose and review a testing software vendor for the trauma commission funded EMS initial education courses. Ongoing work will include review of those exams and resources provided by those vendors. So hopefully that'll help with some of those education needs that we have. Any questions?
So you're involved with that, when we talk about the education, you all are involved with that, so.
Yes.
I think that's good that you're involved with that.
So we selected a vendor to do the testing software. I'm working with that vendor to create a unique and validated test bank that's just for trauma commission sponsored programs. So our questions are not on the internet with a simple Google search. We've created that test bank and we've sent it to OEMS&T just to have their eyes on it as well to ensure that they're comfortable with the content, with the level of difficulty of the questions. And we've created 5 exams, we call them the module exams, and 1 course final exam that will be used for all those classes.
Very good. Any questions for Stacy? Terry?
One more question. So y'all had a state office had a rules revision that had come out a little while back. I was going to say, I don't know if you or Michael would like to give us an update maybe on where that's at, or.
I'll let Michael handle that one.
Those were open as a public comment. There was a lot of public comment on some stroke destination changes. Those have come back to us. We're trying to clarify some of that language. So as they're back, we're working with the Hospital Association and other stakeholders to revise that language. We're also going to add in there at this time from now to the critical care lines to prepare that line to level. So we won't have that done and out for another public comment. September, I'll shoot for a October.
Thank you.
Thank you, Stacy. All right, last but certainly not least, Dr. John Harvey, our Medical Reserve Corps representative. Annual report. And his assistant, Chip, who we've got to be very fond of over the years. We really have.
Thank you, Dr. Ashley, Dr. Dunn, fellow EMS experts around the table here on the Trauma Commission, Liz Atkins and Trauma Commission staff. I appreciate the opportunity. Fred said it's time for us to give the annual report. And I said, oh, good. We finally get to tell them what we've done in the last year. And I actually look forward to that opportunity because without that, it's difficult to understand what all we do. And hearing the discussion today, which has been very engaging, in the fruit bowl that we talk about here, comparing apples to oranges and kumquats, we want to, we realize that disaster response is a kumquat. It's a small but very important part of what we do, and it's actually if we have one where a lot of patients that utilize the whole trauma system get started. So it's been kind of a pet project of mine my whole career, and I'm happy to continue to work with that with the support of the Trauma Commission. Gets into a number of areas like Stop the Bleed. The Stop the Bleed came from the ACS out of disaster response. We were actually one of the first states in the country to introduce it to our legislature and got the project started with the Stop the Bleed kits. I know Brent Roslin at North American Rescue, and I thought the proposal was very good that we give a tourniquet or another Stop the Bleed kit if you ever use one. That's a ploy I've used ever since we started. And I've had a number of my residents or people that have taught with us come back and say, hey, I need a new kit. I say, you got it. Was it a success? And I think reporting out those successes are very important. So I've tried to do that with our annual report. And I realize I'm the only thing standing between you and lunch and finishing this meeting. So I'm going to try to answer questions, which I think is probably the best way for us to communicate. In the report that I have submitted, Gabriella is published it to you in your book, as well as it's on the screen. But in the past year, you can see basically the activities that we've had, which include a number of things involved with training, and happily, not too many deployments on missions this year, although last week we were in fact called by Department of Public Health, and I put this on the table because we sent it to Gabriella this week. We already have the turnaround on our after action report, but they opened 4 shelters in response to the hurricane that came through. We got a call from Department of Public Health. Do you have physicians that could be available for on-call consultation if they have any problems with any of these shelters? I talked to Fred, who put together a roster, and for 6 days, we provided a roster of physicians that were available to the Department of Public Health shelters to answer any questions, give guidance on what we do for emergency medical problems in the shelters. And it worked very effectively. So there's a mission accomplished with the MRC training and background with the doctors to be available. The other reports in here, we've given some educational training on active shooter to Fulton County schools. We've had many of our members continue to work with weapons of mass destruction potential within the state. I realize that's a little niche, but it's going to be very important if we have to deal with it. We have around the state showcased some of our training, and that's listed in the report also with the Cotton Fair discussion with MAG, with one of the healthcare initiatives in our state. But we served that as a deployment drill for our members, and we took the equipment. You can see some of the pictures in there. We even took the K9 team. As you can see, little Chip was the newest member of the team. He actually was able to discuss with that little golden doodle appropriate behavior at a mission response. So those are some of the things we've done in the last year, and I'll be happy to answer any questions. I've included in there our budget provided by the Trauma Commission, which we liberally discuss around the state when we give credit to any of the responses or training that we have and accomplish. Because without that, we'd be another MRC kind of under the auspice of the Department of Health and Human Services. And it's a relatively minimally funded federal program, as most of you know. And we've been able to accomplish things within our state to help with training and with mission accomplishments because of the support from this commission. The last summary part I'd have there is this is 10 years. We got an exclusion to be a state MRC that could deploy and assist anywhere in the state not to supersede any local MRC, but to provide assistance and background support in an area of an emergency or disaster. And it's been 10 years. And we've been able to accomplish that mission through a number of weather-related deployments in the realm of hurricanes or tornadoes that have come through, as well as the big one in the midst of the last 10 years was COVID. And we received the call that this was going to overwhelm medical services. How could we help with medical manpower? We got that through the Department of Public Health, which is the parent organization that we're under in the hierarchy, and Department of Defense, along with GEMA, Homeland Security, because it's important. This is one of the things we had to teach physicians is how you can deploy effectively in an authorized fashion. And you have to work with the state hierarchy to understand that. And that's part of what we train on. So certainly the COVID response, both with the initial physician response as well as the subsequent inoculation or vaccination response, was accomplished with the MRC, and we had a big part in helping to get the agencies to be effective in that response. Those after action reports are a little bigger than this one, but certainly were interesting and taught us all new and unique lessons about disaster response. With that, that's our annual report, but I do want to update you on one thing that Liz came back with our support for this year, our grant, and said, can you do one more thing for us? And that's something I think the Trauma Commission will be very interested in. And I have that to discuss today. That was one of the recommendations that they had for our trauma program. Your report's finished. And that is the combined civilian military response with training for the benefit of both the civilian trauma centers as well as the military. And when Liz called me, she says, you're the one I know that works with the military and the civilian assets. Can you do anything to help us with accomplishing this ACS expectation? And I said, well, understanding it pretty well, as usual, give me a little time and let me see what we can do. Interestingly enough, as Dennis just pointed out, the current articles starting in May that was in the ACS journal about the civilian military combined medical training response, followed up by, unfortunately, it's from our sister state, the University of Alabama, right out I-20, but they detail their program in the state. And we were able to pull also as you know, the ATLS that we all talk about, the red book or the yellow book, whichever book it is, what color it is now. But there's a blue book, and that's just for the military civilian program. So I was able to pull all that very current literature and take it as we had an interesting development in the state. General Cardin, who was our TAG, was promoted. He now protects all of us. If you don't know, he's the deputy commander with NORAD. And that was, I'm very happy for him for that, but we lost a great asset there that understood the public health side of emergencies. But he wanted to be sure before he left that we met the new TAG. So Fred, Dr. Hayes Wilson, who works with me now to co-direct the MAG MRC, and Fred Jones went to meet the new TAG and were able to carry this proposal forward. You asked if I could set up some meetings or get results. Well, we've already, I think, had buy-in and support from the new TAG. General Wilson is our new 2-star TAG, and we talked about this combined training. And he said, well, I think we already do some work with this with Grady. And I said, okay, you'll have to enlighten me. And they do have some of the TECC training that's combined. But I think we probably benefit to try to make it a more formal thing between the trauma centers and the military physicians that are in our state and have training opportunities. He was very open. He said, well, what could we start with? And I said, well, the easy things are stop the bleed and ATLS. We do those all the time. It's outreach through the trauma centers. But certainly the embedding of training within the trauma centers, I think would be something that I could propose to the trauma center directors and the trauma commission. And he said, great, turned to his chief of staff and said, work with Dr. Harvey and make it happen. And I said, well, we have a meeting next week with the trauma commission. I can commit to at least bringing it up. The MRC would be happy to facilitate some meetings. You pick your right people and we'll talk to the trauma centers. They can pick their right people and we can put it together. So that you wanted, I said I didn't want to be bound to a deliverable on our grant because I didn't know if I could accomplish it through all of the agencies, but I'm very encouraged with the progress that we've had so far. And I present that today for discussion for you, Dr. Ashley and Dr. Dunn, to discuss with the Trauma Commission on where we go from there.
Well, I think, Dr. Harvey, that's really great work, spectacular, sort of given a task. I think you framed it well. You know, didn't really know what the task was, but I would consider it intelligence or exploratory discovery task. And it's very encouraging what you found out, and certainly the contacts that you've made at a very high level in the military to try to get a connection for our ACS, we'll call it deficiency, but an ACS area that they wanted us to work on as a state. To try to align the MRC, the commission with the military. So I think you've made tremendous success in getting us to this point that we can even talk about it. So I see Jim's ready to go. The mic, a former military man. Jump in, Jim. Any comments?
So I guess a qualification here or a clarification. Liz, does this have to do with the cooperation between the military and the civilian side for trauma readiness for the military? Or does this have to do with just coordination in general between military and civilian groups regarding trauma?
Yeah, coordination in general. I think, as Dr. Harvey showed you year after year with report after report, in practical applications, it works really well. But when the ACS came, and I'm not saying it's all driven by ACS, but we don't have anything in hard copy that says when this happens, we do this. We know that it works, but what they wanted to see is more, you know, when they come to, it's the same thing when they come to your center, they want everything codified. You know, they want some kind of policy, some kind of, one of the things Dr. Harvey and I also talked about is the reciprocity between civilian surgeons and military surgeons to be able to, you know, kind of work back and forth like that. That was another thing. We were trying to pick off some low hanging fruit things that, you know, with his contacts, as he's already done, have the conversation about how do we get this a little bit more like formalized, for lack of better.
Sure, I know there's obviously people may or may not be aware of the Mission Zero project that's been run through Congress about making sure the military is ready for, you know, wartime and trauma-related activities. And so they want to push military members into civilian trauma centers to get them trained. I think Grady does this very, very well. And a couple other centers across the state do this well. We are currently not actively involved in that, but I think one of the biggest needs for civilian centers and one of the needs for the military is trauma nurse training. And there's obviously a nursing shortage across the country. And if we can partner with the military, bringing military nurses into the civilian centers and give them exposure to high-level ICU, trauma resuscitations, that can kill two birds with one stone and address two needs, their training opportunities and our potentially manpower deficits. Now, it's not a one-for-one because they're there to learn. They're not there to provide, you know, FTE support. But I think it's a win-win for both centers. It gets a little bit more tricky with docs because based on the contracts of your docs in the hospital, are they salaried, are they FTE, are they work RVU or whatever. But I think The biggest need I would think would be nurses and techs personally, but I don't know that for sure.
That was General Wilson's viewpoint. He discussed it specifically with nurses and with PAs and advanced practitioners. As you know, the military uses a lot of 68 whiskeys, which you and I understand. And he felt like that would be the place to start. You know, Liz talks about low-hanging fruit. I talk about luscious kumquats. You know, if it's a win-win for both groups, then it's something that will be easily accomplishable. And you bring out what's discussed in this University of Alabama paper of, well, gee, the payment for a federal agency through an employed military doctor in an employed hospital, it's problematic, but there is a way that they've done it. So we have templates that can work. I don't want to reinvent the wheel. I'd rather use their training wheels when we have them. And that's why I pulled these papers. That was included in the package, right, Gabriella, we sent out. I think I can, well, I know I can transmit those papers for you, and we can send them to all of the members of the commission if you want to read that background. So that's the groundwork that we've already accomplished in what Liz gave me as homework. And that's kind of not on our annual report from last year because that started as of right now. But we went ahead and I chose the seize the moment to try to go ahead and work with that project.
So I think this may sound a little unusual for me because I usually know where I'm going, but I don't have a vision for this like we should do X. But I am intrigued by your research and your work and bringing such high level military discussions. Obviously you have contacts into the discussion. So I really think I would very much like to develop, I'd like to go to the next step is what I'm trying to say and have the commission and if the commission agrees, I would like to move forward with discussions. Like you said, you know, the general wanted to meet and have some discussions, and I think we should meet and talk and see what we should do and formulate a plan. And if there's something there, and if we meet and there's not, that's okay. If we meet and there is, then we've gained ground. So I mean, I think this is exciting and worth exploring and discussing is sort of where I'm landing. I mean, I opened up. What's everybody else think? Sort of. You have any thoughts, Todd, or Rob? I mean,
yeah, no, I think it's fantastic. I mean, we have a pretty strong relationship with the AMCT3 program and a lot of other military programs. It's been a really valuable partnership. And I can connect with Liz Benjamin also, just to give you our perspective and our experience at Grady and what that's like.
I'll actually be talking to her at the next Region 3 or RTAC meeting that's coming up in about a week or so.
and you know, I don't want it to lead to me like we're going to do it just like exactly like your program. Maybe we don't need that, or maybe we do need another program, or maybe we just need I'm just intrigued by the fact that that there's interest and that you've made a connection. I just think we should talk. So I'm really an open slate. I don't mean to step on anybody's toes or. You know, certainly a Grady's program, not to like compromise your program in any way, but I think there's opportunities here that we can explore for our state. So I guess, Liz, what would be, Dr. Harvey's coming and asking for a meeting, or, you know, do we want to move forward with a meeting? I'm getting the feeling that everyone is okay with that. How do we make that happen on next steps? Or we just agree that we will meet and then you all maybe work out how that works offline?
Yeah, I think so, because Dr. Harvey has all the great contacts. So once we know who we need at the table, then we just coordinate the sit down, you know, like a Zoom call, I think.
I'll leave that between you and Liz to find the appropriate people that want to be at the table and the appropriate expertise.
We'll continue to work with pushing that initiative forward. The one other thing we remiss if I didn't discuss that is in our annual report, and we brought a demonstration. I won't belabor the meeting time, but it's really cool. I have to keep physicians interested in our training and what we do. We have noted one of the things that's often a source of problems is how to evacuate patients from a disaster area. And that usually involves helicopters and landing zones. And we've taken that on as part of our training. Fred Jones and a couple of us have taken on landing zone instructions. And one of the things I've always worried about is that you get around a helicopter, it gets to get dangerous in a hurry. We have worked with an international company on a training module that involves an area like Dennis and the new virtual platform where you wear the really cool glasses and you get up there. And I actually did it with our program the other day on how to marshal or bring in helicopters in the aircraft and experience the disorientation that you get when one's coming at you too fast and you're trying to slow him down and all of that. We brought that and we have that to show today. And I think Fred has it activated right outside the room. So if anybody's interested in having a little fun, we did it the other day and it got so animated that Chip and Jack, our canines, were jumping up and down. They thought us doing all this waving with our wands that we had for the virtual platform is very instructive, very realistic, and it is another adjunct of training that I think we'll have in the future for skills that are used that we don't necessarily always have to accomplish in a dangerous environment. But that concludes my report, and I'll be happy to answer any questions that you may have.
Okay, thank you, Dr. Harvey. Any other questions? Great work, great report. Appreciate you.
We continue to appreciate our Trauma Commission funding, so thank you very much.
Okay, with that being said, I don't have, we'll move into new business. I don't have anything new on my agenda. Is there anything come forth, Liz, that I don't know about?
No.
Okay, this is a controversial and tough next motion, but can I get a motion to adjourn? Oh, what? I do want to thank our staff, outstanding guys. The new format with the packets, as usual, always great. You all do a great job, and we appreciate you. We're very blessed. Thank you. Now, can I get a motion, Jay, to adjourn? All right. I don't have one. I need a gavel. But can we put that in the budget, please? All right, we stand adjourned. Madam Chair, can we get a gavel? Yeah. An axe, an axe. Let's get an axe. Let's get an axe. I need to put this in.